Hello, everyone, and SSBMT.
Yes. So that's why we need Hatem. So can we invite all for a group photo before we start the session? So لا ناخذ صورة. لا لازم انت معنا وصورنا بعدين انت. نعطيك اياها Colleagues, members, please to the stage. Hatem, ready? Hatem? All to join, please.
صورة صورة كلنا كده عاوزين صورة.
ابشر المصور كأنه تصور سيلفي.
بسم الله ما شاء الله. Dr. Shad, Dr. Ahmed Shad, you are not allowed to drink any coffee in the presence of a photographer. We will send you a picture to your wife showing that you are escaping leaking from home. زملائنا اللي في الخلف لو سمحتوا تقدموا. المؤتمر النهارده ما فيش فيه مكان للي قاعدين ورا، كلنا قاعدين قدام.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Welcome to afternoon session for this SSBMT meeting. We will have the first speaker. It's my pleasure to introduce Dr. Musa Zahrani. He's assistant professor and consultant hematology with a special interest in malignant hematology and particularly lymphoproliferative disorder. He published also a lot of journal in high impact factor journals. He's holding master's degree in health science from University of British Columbia. Dr. Zahrani is going to present navigation and evolving landscape of relapse refractory chronic lymphocytic leukemia, management update in 2026.
Thank you, Dr. Mohammed, and thanks for the organizer for the invitation. It's my pleasure to be here. So I will be talking about some updates in relapse refractory CLL. It's my disclosure. So we will go through briefly over a couple of slides on the first line treatment selection, and then the focus of this lecture will be on the relapse setting. So we will talk about factors that can influence treatment sequencing in CLL and relapse refractory treatment selection, and then we will go over the clinical trials update. So there are several treatments spanning multiple drug classes available in the treatment in frontline CLL, as we know based on BCL2 inhibitors or BTKI inhibitors, and whether they're used in a continuous fashion or time-limited fashion. And there are different ways that we have to check the baselines with the genomic aberrations, but especially looking at TP53 aberrations and the IGVH mutation status, they are recommended before starting therapy because they can influence prognosis and the treatment selection. So the targeted therapies should be the first line treatment over chemoimmunotherapy and could be either, as we said, fixed duration or continuous. And there is no evidence that starting either class before the other leads to better outcome. So we still have different options in this setting. There are multiple factors that are important while selecting therapy frontline, including availability of treatment, age, drug-drug interactions, baseline cardiovascular complications, and also renal function and tumor lysis prevention. In the most recent NCCN guidelines, you can see that they divide options whether they are TP53 aberrated or not, and they have preferred options and less preferred options, and we can see that actually both continuous and fixed treatment options are there, including the combination of BCL2 and BTKI. So venetoclax acalabrutinib based on the amplified trial, and venetoclax or obinutuzumab based on the CLL14 trial, or the continuous therapy with the second generation BTKI are the preferred agents, whether TP53 or not. So now just some overview on the factors that can influence treatment sequencing. So there are multiple factors that help us decide on the sequencing, including disease characteristics, patient factors, drug mechanism of action, efficacy, safety, prior therapy and response, accessibility and availability of medications, prognostic markers, and also more important is patient preference. Depending on this, then we will have different scenarios. Whether you're starting first line with the second generation BTKI, then you can consider in the second line relapse setting venetoclax-based therapy, or if you start with a venetoclax-based therapy, then you can choose a BTKI. But now we're in an era where combination therapy is also frequently used, and we will discuss about these options. So the options in the relapse refractory setting include multiple drug classes, as we said initially. While there are many approved options for treatment of CLL, there are certain factors that may influence one treatment over another, not that different from the baseline or frontline selection. So for example, 17p deletion or TP53 mutations are important in consideration of which line to choose. Also, patient disease and factors, as we said, IGH mutation, TP53, performance status, age, fitness, existing comorbidities, and also what kind of first-line treatment the patient has received, and also what kind of response the patient has received in the first line, and whether the patient actually progressed or was intolerant to the first line. All of these are important in deciding the next line of therapy. So you can either do a class switch and use a different mechanism of action, or you can use the same BTKI going from covalent to non-covalent factor. So, and also you can also use the same class of medication if the patients progressed or relapsed later, over long time. For example, the BCL2 inhibitors, if you use it as a frontline in a time-limited fashion, and the patient had late relapse, more than 2 or 2.5 years, then you can actually reuse the same regimen with a venetoclax-based regimen. We should also have consideration of the resistance mutations, and especially with covalent BTKI, and consider non-covalent BTKI in case of a mutation. So now going through some updates on the major landmark clinical trials. We're all aware about the Murano study. This study included patients with relapsed refractory CLL, randomized patients to chemoimmunotherapy with bendamustine rituximab 6 cycles versus venetoclax rituximab with a primary endpoint of progression-free survival. We see that in this study that they included patients with TP53 mutation as well as high-risk features like unmutated IGVH in about 70% of patients. In the prior therapies here, it's important to mention that patients with prior BTKI only constitute around 2% of patients or less. So this is not something that we can apply to patients who have received already BTKI therapy. Despite that, we can see that progression-free survival was quite remarkable in favor of venetoclax rituximab over chemoimmunotherapy, with a median progression-free survival reaching 53.6 months. This benefit was seen whether the patient had TP53 or not, or 17p deletion or not. And we can see that even those patients benefited from venetoclax rituximab as compared to bendamustine rituximab. This was sustained over longer follow-up, over 5-year follow-up. And we can see also that there was an overall survival benefit of venetoclax rituximab over longer follow-up. Also, the time to next CLL treatment benefited with venetoclax rituximab as compared to bendamustine rituximab, and it has led to deeper remission with significant MRD status at the end of therapy. There was no new safety concerns reported apart from the known toxicity of venetoclax, like neutropenia, for example, or tumor lysis in a very rare situation. So the evidence of using venetoclax after BCR inhibitors are kind of limited based on either retrospective or small phase 2 trials, but we know that it can work. So venetoclax is active following the BCR failure based on this small trial, and it leads to a significant PFS benefit and overall survival as well. Retreatment with venetoclax was tested in the Murano trial, so a small number of patients, but the overall response rate was more than 50%, about 55% in patients who were retreated with venetoclax. So you can consider retreatment, especially in later relapses. How about if you started with the venetoclax-based regimen and then you want to consider BCR, BTKI inhibitor? This comes from real-world experience from different countries, including Europe and also from Australia. And it has shown that the overall response rate is quite remarkable of 84%, especially those who are BTKI naive. But even if they are BTKI exposed, over 50% will respond. So for BTKI naive, selection of BTKI after venetoclax can result in high overall response rate and durable remission, and it remains a valid option in this setting. Now, discussing the ASCENT trial, this is a trial that randomized patient with relapsed refractory CLL to chemoimmunotherapy versus acalabrutinib. And it included patients with 17p deletion and complex karyotype and mutated GVH in 77% of cases. And we see that acalabrutinib monotherapy was superior in terms of progression-free survival over chemotherapy. And the patients with 17p deletion actually did very well with this regimen, and resembling even the progression-free survival of those without, but it's much better than chemoimmunotherapy. And the patients with unmutated status did worse as expected. The overall survival was reported also in this trial. It was superior in the acalabrutinib arm. So now talking about after combination of therapy, we know this trial that was reported in the older days where patients who, included in this trial included patients who received the combination of ibrutinib and venetoclax. However, in this trial, the prior use of BTKI or BCL2 was very rare. So it's not that relevant to our current practice. However, we do get a very important signal that the combination therapy is very effective and it leads to deeper responses and deep MRD status. And it leads to very good 5-year progression-free survival of 78% and overall survival of 91%. This was prior than the current era of using these regimens frontline. Now, how about patients who are intolerant to ibrutinib? So we know from this trial, ACL 208, they included patients who had received at least one prior line of BTKI with ibrutinib, but they basically had side effects or intolerance to ibrutinib. So they were switched to acalabrutinib, and then they looked at their endpoints of progression-free survival and tolerance. We can see that the overall response rate was very high, of 72% of using acalabrutinib after intolerance of ibrutinib. The median progression-free survival was also very good, as expected with this treatment. In terms of recurrence of commonly happened side effects with ibrutinib were actually quite low after switching to acalabrutinib, and only 12% discontinued acalabrutinib during this trial. So Elevate RR is a landmark trial that included patients with relapse refractory CLL with the presence of 17p deletion or 11q deletion, and randomized patient to either ibrutinib head-to-head to acalabrutinib with the primary endpoint of progression-free survival. We see that this was a non-inferiority trial, and it means that acalabrutinib was not inferior to ibrutinib. So they have the same efficacy, and also overall survival was not different. However, when it comes to side effect profile, they differ. So ibrutinib leads to more diarrhea, acalabrutinib to more cough and headache, arthralgia and hypertension were more common in ibrutinib, and contusion or bruising and atrial fibrillation were more common in ibrutinib. Ventricular arrhythmias did not happen in acalabrutinib, while it happened in ibrutinib. And the accumulation of flutter, atrial fibrillation, and hypertension over time were higher with ibrutinib. So it is a safer drug in terms of cardiovascular toxicity, as well as other toxicities, including the one shown in the slides: bleeding, diarrhea, arthralgia. Alpine trial is a kind of a similar design with head-to-head comparison with ibrutinib versus zanubrutinib. Also included patients with the deletion 17p, but also patients without, with a primary endpoint of overall response rate. And we can see that the baseline characteristic of these patients, and it was balanced, but it also included patients with high-risk features, complex karyotype, for example, and TP53 aberrations. We can see that the progression-free survival actually was superior in zanubrutinib, unlike acalabrutinib study, so 65 compared to 54%. Even in the high-risk patients with 17p deletion, TP53 mutation, the zanubrutinib was superior to ibrutinib in this setting. The overall survival, you can see a trend, but not that statistically significant. In terms of cardiac side effects, they were less with zanubrutinib, except hypertension, which was similar, but less atrial fibrillation and less time to occurrence of cardiac disorders. And the cardiac adverse events leading to treatment discontinuation were also less with zanubrutinib, and the fatal cardiac toxicity were 0 in the zanubrutinib, but it happened in 6 patients in ibrutinib, so it is much safer drug and more effective. In the last ASH, there was a report of 6-year follow-up of a long-term extension of the Alpine trial. So 189 patients enrolled in this long-term extension trial, and they looked at their outcomes. So we can see that the progression-free survival in the overall population remained quite high, and when they adjusted this for COVID, the median median progression-free survival was 60 months, which is quite prolonged. Also, when they looked at the same progression-free survival after adjustment for COVID, it was 50 months, and it is quite remarkable also. With longer follow-up, the prevalence of side effects remained stable or decreased over time, so there was no new signal reported. There was a make analysis matching adjusted indirect comparison between the different BTKI in this setting. And with this, they included data from Alpine and Elevate RR. So basically what we got from this is that the efficacy of these second generation BTKI is actually similar to ibrutinib even. So in terms of efficacy, they're the same, but they have different side effect profiles, and this is what we can get from this. So now, more important is to discuss patients who failed covalent BTKI and venetoclax, because I think this is the scenario that we will face with most of the patients nowadays. If you look at the NCCN guidelines, you can see that the options include either enrollment in a clinical trial, consideration of CAR-T therapy, or non-covalent BTKI like pirtobrutinib, or other agents. Allogenic transplant should be considered in young patients with TP53 aberration. So these are the factors, again, to decide on the third line and beyond. So patients' disease and factors, especially TP53 aberration, performance status, age, comorbidities, the drug class mechanism of action, whether they have resistance to previous treatment or not, and especially with the covalent BTKI, duration of previous response, whether they progressed or intolerant to the previous therapy. So these are all important factors. So consideration for non-covalent is important if you have patients who relapse after a covalent factor or have resistance to previous therapy. And allogenic transplant, as we said, should be deferred as a last therapy for patients who are high risk, young, and fit. So the Bruin trial is a trial that looked at the use of pirtobrutinib non-covalent BTKI compared to idelalisib, rituximab, or BR. And eligibility included patients, not clear here, but it included patients who at least received one covalent BTKI previously. And the key endpoints included progression-free survival and safety. So we can see here that patients included in the study had patients with bulky disease, high-risk features, including 17p deletion, unmutated GVHD, complex karyotype, etc., 11q deletion in some of these patients. And the progression-free survival, we can see, was significant with pirtobrutinib compared to the control arm. And the time to next treatment also was significant. 24 months with pirtobrutinib compared to 10 months with BR. Whether they are venetoclax naive or treated, they benefit, and it seems like they did better if they are venetoclax naive with a median progression-free survival of time to next treatment of 29 months. The overall survival is not mature yet, so awaiting longer follow-up, but there is no significant overall survival between these arms. In terms of side effect profile, actually the drug was well tolerated. It can lead to some cytopenias, but not that significant. And it also can cause cardiac side effects, but much less compared to the other BTKIs. It can also lead to bleeding, but this is also quite low. So it is a well-tolerated drug. Recently, there was a press release from Lilly about this clinical trial, which is called the CLL 322, that compared pirtobrutinib VR versus VR. I don't have a slide on this trial, but this has the potential to change the current standard of care, because the addition of pirtobrutinib to VR in the relapse refractory setting led to better progression-free survival, and I think it probably will lead to approval of this regimen in the near future. So just to summarize the treatment sequencing, so if you start in the first line with the covalent BTKI regimen, then you should think about what was the reason for discontinuation of the BTKI. Was it toxicity? And if so, then you can use another BTKI, which probably will work. However, if the patient progressed on the BTKI, then you should use a different class of medication, which is the BCL2 inhibitor or venetoclax-based regimen, or non-covalent BTKI. So pirtobrutinib is approved after one line of previous covalent BTKI. So it can be used in this setting. If you use in the front line BCL2 inhibitor, then you should also ask the same question. Did they progress or they were intolerant to previous therapy? And if so, if they were intolerant, then you can use a covalent BTKI. If they have completed the fixed duration and they relapse later on, and they relapse more than 2 years, you could also consider retreatment. Or you can consider also covalent BTKI, and if they have failed after that, then you can consider non-covalent BTKI after this. So CAR-T, based on the Transcend CLL-004 trial with Lysocell, shown promise in this setting after failure, especially of two mechanism of action drugs. So after failure of BTKI, especially after failure of non-covalent BTKI, it should be considered in patients who are fit. Just to keep an eye on this new class of medication, which is the BTKI degrader. We're still awaiting future result from this type of medications. They're not approved yet. So this is the last NCCN guideline in this setting of relapsed refractory. You can see it's either with or without 17p deletion. The preferred agent is whether it's fixed duration or continuous, venetoclax or obinutuzumab, or continuous therapy with acalabrutinib, zanubrutinib, or non-covalent if the patient has received at least one covalent factor before. And there is other recommended regimens in there. So if they fail, then you can consider CAR-T or non-covalent if they have not received the non-covalent. So take-home message, TP53 aberration at the time of relapse may influence the choice, just like in the front line, and also consideration of fixed versus continuous therapy is important. Variables to decide differ, and we need to think about toxicity, previous toxicity, progression, intolerance, and also side effect profile, and also whether the patient is fit or not. Pirtobrutinib can be effective, especially on those who progress after covalent BTKI, and the cellular therapy has shown promise in the later lines of therapy. With this, I conclude, and thank you very much.
Thank you, Dr. Zahrani, for this comprehensive review in relapsed refractory CLL, and thank you for being in time. Do you have any question?
Thank you, Dr. Musa. Question regarding relapse setting. Which patient profile that you will consider fixed regimen versus continuous treatment?
For what?
Relapse setting. Which patient profiles that you will consider fixed type of regimen versus continuous treatment?
So there are several factors that help us decide, but as I said, TP53 aberration, TP53 mutation or 17p deletion is one major factor to consider continuous rather than fixed treatment duration. The other thing is patient preference. I guess patients who want to have a fixed duration treatment, even with high-risk features, I think if the patient is strongly wanting to have a fixed treatment decision, then I think that should be offered also.
Thanks a lot. For patients who present for the first time with a transformational type of CLL, they present with a lymphoma transformation, a diffuse large B-cell lymphoma or whatever, would you give these patients immediately after they finish their intensified chemo protocols for diffuse large B-cell lymphoma? You give them, or you start anti-CLL therapy, or you wait and see if they are not eligible for any transplantation or any other line of therapy. So you give chemo-immuno followed immediately by CLL therapy, or you wait and see the CLL whether they will come back again in a stagnant, asymptomatic, the usual patients for EV-CLL.
Yeah, so I haven't covered Richter's transformation in this talk, but patients who transform to large B-cell lymphoma, I think one of the factors that we need to know whether they are clonally related to CLL or de novo. For de novo, we just treat it like DLBCL, like 6 cycles of R-CHOP or Pola-R-CHP. Following that, nothing will be done. So you look at the CLL, whether they have indication to treat or not, and then you treat as such. For those who basically are clonally related, I think the CLL should be treated, but after trying to cure the large transformation first with chemotherapy. So after that, you can treat the CLL.
How would you actually assess the concordance between the CLL clonality and diffuse large B-cell lymphoma clonality? Would you do additional genetic testing of the diffuse large B-cell lymphoma, or what?
It's based on the IGH rearrangement, but I think we need a specialized lab to test. I'm not sure if we have it in Saudi Arabia, honestly, but I think this is an important consideration.
Thank you, Dr. Musa.
You're welcome.
So we start with the second session.
Thank you very much.
It's my pleasure to introduce Prof. He Huang. He's the director of bone marrow transplantations of the First Affiliated Hospital at Xinjiang University School of Medicine. He's also director of Hematology Institute in the same universities. Prof. Huang specialties in clinical and basic research of stem cell transplantation and cellular therapy and stem cell biology. As a corresponding author, he has published over 330 original papers in highly impacted journal. For his outstanding achievement in stem cell transplantation, Prof. Huang was awarded the National Prize by State Counseling twice in 2003 and 2015. Prof. Huang will present to us ARMOD and in vivo next generation CAR-Ts. It's a pre-recorded session, but he'll be available for question.
Hello, everyone. And first, I'd like to thank you, Professor Aha and Professor Alaska, invited me attending the SSBMT and EBMT joint meeting. It's my great honor to participate in this meeting. I'm Dr. Huang, come from the First Affiliated Hospital, Zhejiang University School of Medicine, Hangzhou, China. Today, my topic is armored and in vivo next generation CAR-T. It's my disclosure statement. We all know the main challenge in CAR-T therapy. We need the enhanced CAR-T. Because it's in clinical practice, we know there are some patients high resistant or relapse late, just like after the acute lymphocytic leukemia treatment, relapse about 60%. For no relapse and refractory non-Hodgkin lymphoma, complete remission just about 50%. So we need the enhanced function for CAR-T cell. Another point, that because until now the individualized manufacturing induced clinical long time waiting and high cost. So I think that maybe we will need the more advanced manufacturing, just like in vivo CAR T cell. So today we will focus on these 2 points. Future CAR T development, 2 key directions. How to modify engineering the CAR T cell ex vivo, and how to develop the CAR T cell in vivo. The generation of the CAR T technology, we all know first generation from Professor Escher, and second generation can be used in clinical practice and published by the Professor Michel Cedrin, and now we will develop the 3rd generation and the 4th generation. So new generation CAR T, the characteristic is cytokine expression or the armored, the track CAR T cell. The taper of the armored CAR T cell, one is the cytokine secreting armored CAR T. CAR T cells are engineered to constitute to inducibly secrete immunostimulated cytokine. Another second is a bispecific T cell engager secreting CAR T, just like the NK and the T cells are both activated and prelude. Another third is the checkpoint inhibitor secreting armored CAR T. CAR T cell secreted antibody fragment or the inhibited checkpoint that block immuno checkpoint blocker. There are some other ways, just like the chemokine receptor armored CAR T, extracellular mixture modifying armored CAR T, and inducible suicide genes armored CAR T. Example of the armored CAR T cell in clinical trial, and we all know here is there are some different cytokine secreting armored CAR T, just like interleukin 15, interleukin 21, and interleukin 18, and focus on the solid tumor clinical trial and the hematological malignancies clinical trial. Cytokine armored CAR T cell, effect of the cytokine secreted by the armored CAR T cell on different taper of immune cell. Virus cytokine demonstrated the ability to alert immune cell phenotype in favor and more robust and tumor response. This work published by Professor Kajun in New England Journal of Medicine enhanced the CAR T cell therapy for lymphoma after previous failure. This product is human CAR T targeting CD19 and combined interleukin 18. An autologous anti-CD19 CAR T cell that constitutively secretes interleukin 18 with 4-1BB as a co-stimulated. It's manufactured in a rapid 3-day process that is designed to preserve stem cell-like characteristic and reduce exhaustion. Total infusion CAR T cell about 3 million. A total of 21 patients with refractory and relapsed disease were enrolled. One patient had previously failed commercially available CAR T cell manufacturing and was included in study. The remaining 20 patients had either not respond or relapse after CAR T cell therapy. And 3 months after infusion, 81% of patients achieved either a complete or partial response, with 52% attaining a complete response. The median follow-up time was 17.5 months, and the median duration of the response was 9.6 months. CAR T cell expansion detection was across all those cohorts during the 2 years follow-up period, and about the 75% patients remained detectable in peripheral. The CAR-T, CD19, and interleukin-18 product contain a high proportion of naive T cell compared to the previous anti-CD19 products. All the clinical trial or the study and interleukin-10 armored CAR T cell for refractory and relapsed diffuse large B-cell lymphoma. All the cooperated Professor Tang Li has published in Nature Immunology to 2021. Interleukin-10 armored CAR T shows metabolically armored CAR enhanced metabolic activity, enhanced the proliferation and the cytotoxicity, enhanced the stem cell, anti-like, anti-tumor memory. In vivo and in animal model and in vitro, the study shows the lymphoma xenograft model and metabolically armored CD19 CAR T cell induce robust and the durable tumor control. All clinical studies shows the eligible patients 18 and met CD19 and interleukin-10 manufacturing, and total is about 11 patients approved since all the study and allocated 4 doses. And we can see the ongoing expansion dose is very low dose. The ongoing follow-up. The safety analysis and the efficacy analysis shows is very low, just like about the 2.3 thousand per kilogram, responding to 0.1% dose of the commercial products. Leukapheresis can be replaced with the whole blood correction. For all the study shows complete remission, about 90%, overall response 100% for refractory and relapsed patients. CAR T cell expanded dramatically in all those, and we can detect in all the patients the peripheral blood, the CAR T expansion. A single cell analysis reveals that the interleukin-10 armored CAR T cell escaped upgraded expression of the effect gene, just like the BAT and the FAST and the INFNG, and the Stanley's memory gene, SELL, and another genes compared with the conventional CD19 CAR T cell. For another point, we can see the armored CAR T can be inhibited as a checkpoint. This work in our group published 2 years ago, and no virus PD-1 integrated CAR T cell potentially eliminated the tumor cell. So such the patients, we use the CRISPR-Cas9 scan no virus and deliver this CAR gene, CAR structure into the PD-1, a high rate 87.5% complete remission and durable response in clinical study without grade 3 CIS or ICANS in 8 patients. And we can see such the actual medulla MS and can dramatically disappear after the CAR T therapy. RNA sequencing analysis indicated that antenated expression of the inhibitor receptor shows is more efficacy in peripheral blood can be treated the diffuse large B-cell lymphoma. So another pathway is the bispecific killer cell engaging secreting CAR T cell. This work in our group published in Nature Biomedical Engineering this year, and we can see the bispecific killer cell engaging secreting CAR T cell redirected nature killer specific to enhance anti-tumor response. Bispecific bicistronic expansion system to produce CAR T cell and CAR NK cell secreting responding ICEs And so we call it the bispecific killer cell engaging secreting CAR T cell. CAR T cell and the CAR NK cell secreting BiKey and BiT into the culture media through the weakly and enzyme-linked immunosorbing assays shows its effective secreting. CAR T secreted BiKey and CAR NK secreted BiT both had identical growth covers and the proliferative capacity with the unstimulated or antigen stimulated comparing with the common T cell or the CAR NK cell. Suppression of the ICE and no significant impact on CAR-mediated rinses of the target cell. In futures, we detect unimpaired function of CAR T cell and CAR NK cell secreting ICEs. Animal model shows the prominent efficacy of the BiKey secreting CAR T cell combined with the NK cell against B cell lymphoma and leukemia in mouse model. So we look forward to seeing this bispecific killer cell engaging secreting CAR T cell in clinical trial. The second point of this talk, and we will how to develop the CAR T cell in vivo. In vivo CAR T cell engineering, two kinds of the delivery system for in vivo CAR T engineering. One is the lentivirus delivery. So we will target the ligand, use genes, stings element, and another is targeted lipid nanoparticle delivery. So such the two-pass delivery system, and we can see the in-chain cellular mechanism and the expression kinetic in vivo CAR T engineering. Lentivirus system, we can see the target ligands and then the endocytosis, reverse transcription, genome integration, and the CAR expression suffers of T cell. Is the durable CAR expression. Another pathway is the LMP, and we can see the target ligands, the mRNA in endocytosis, and through the translation of the cell plasma and expression CAR structure suffers of the T cell. This is the transient CAR expression. Key advantage and limitation of the ex vivo and in vivo chemical antigen receptor T cells therapy technology. We can see there are some difference and advantage limitation in vivo and ex vivo CAR T. In fact, there are many clinical trials ongoing in vivo CAR T cell. Here shows is about the viral delivery companion, and just the Umoja, Interlulus, Ensobiotech, and there are some clinical study or the preclinical study ongoing. The CAR target about the CD19, CD22, CD20, or BCMA, and such the target. There are some many companies carry out clinical trial and no viral delivery companion, just like the Capstan, magic RNA, creatine area. So use the delivery system and the LMP, and we can see the target and the CAR about the CD19 and the CD22 or the BCMA and another TROP2. This published in Lancet last year from the China group and the Tongji Hospital in Wuhan. in vivo B cell manufacturing antigen B cell therapy for relapsed and refractory multiple myeloma. This system is a nanobody targeted immunoshield lentivirus vector, and the engineering such as the modifying lentivirus, and total 4 patients, 5 treatment line of the 4 patients. We can see all the patients is refractory and relapsed multiple myeloma. The adverse events in the early and the late phase. So the 4 patients suffer from the CRS. One is grade 3 and two is grade 3 and 1 is grade 1 CRS. Another patient and have the hypertension and lymphodepression. This clinical efficacy analysis shows the extramedullary disease were all eradicated. After the PET-CT scan, after the CAR T therapy, day 28, we can see the extramedullary mass is disappear. It's all the group work. Also, we will ongoing the study lentivirus gene 2 viral expansion targeted lentivirus for treated for the lymphoma, non-Hodgkin lymphoma patients. This is the actual, we can see the in vivo animal model shows the efficacy for such the treatment. So these are patients, is Burkitt lymphoma, and we can see the such as before treatment and the burden and the baseline, and there's many mass and PET-CT scan shows is significant the active medulla. And we can see after treatment and the CAR T peak value about 151 and about the patients is reached the complete remission. The adverse events is grade 1 CRS and no ICANS. So the cytokine cover, we can see the copy number is reached the peak about the day 12, and the serocytokine levels, and we can see interleukin 6 is about the day 1 until about the day 17, the high level. So for another virus LMP system, and the first case come from China, Anhui Hospital, and the in vivo CAR T cell for SLE. In vivo CAR, CD19 CAR therapy for refractory SLE patients. This work is carried out is the HM2301 is an engineering the CD8 the T cell targeted LMP encapsulating CD19 CAR mRNA. The scoring on the systemic lupus erythematosus disease activity index has decreased, indicating that disease activity in all 5 patients after treatment. CAR cell expanded in vivo peak and 7.33% of the circulating T cell on day 10. B cell aplasia persisted until month 5. Surrender 2K scoria reached 0 from month 2 onward. It's all the group data shows is the no virus, lentivirus, SLE treated the patients. And important in all the clinical study shows the patients. An actually lymph node biopsy was performed on day 12. Histological analysis showed the disappearance of the lymph node folliculus and the germinal center, replaced by dense CD3 positive T cell infiltration. Immunohistochemical staining for B cell lineage marker was entirely negative, confirming tissue level B cell clearance. So are the conclusion, armored CAR-T, especially cytokine armored CAR-T cells, should prominent efficacy and safety in hematological malignancies and low dose, and this approach may be extended to solid tumors. Lentivirus vectors are engineering to directly transduce T cell in vivo with a sustained CAR expansion. Further application might focus on the malignancies. LMP deliver mRNA or sometimes the CRISPR components encoding CARs directed to T cell in vivo with the transient CAR expansion. Further application might emphasize known malignancies just like autoimmune disease. So finally, I'd like to thank you for your invitation, and also thank you all the clinical team, immunological immunology laboratory, international experts, all the cooperated by company, and thank you all patients and family. Thank you for your attention.
Thank you, Professor Wang, for your excellent and elegant presentations. I think we have time for one question. I think he will join us.
Is he listening, and can we reach him? He's available now?
Yeah.
Dr. Huang?
Hi, hello.
So,
Nice to see you.
Yeah, this is Saeed from the hematology section and transplant unit of the old era, or the old-fashioned hematologists. Do you think the armor type of T cells can function optimally against the histocyte-rich, T-cell-rich, B-cell lymphoma if they are targeting CD19 only, or you have an additional armamentaria to help improve their efficacy against other lines other than CD19?
I think it is a very good question. Because of the targeted CD19 targeted CAR-T, we have the commercial used for the lymphoma and the leukemia. But with the light to the challenge, how about the just like the non-Hodgkin lymphoma, some half patient is not reached complete remission. So I think the armored CAR use the cytokine with have the interleukin 18 or the interleukin 10 indicated the enhanced function. I think the cytokine secreting can be the approved T cells proliferation, and also can enhance the function of the CAR-T cells take just like leukemia and lymphoma. So all the clinical study shows is a low dose, just like the 0.1%, can achieve the complete remission. So we think that in future, just like the armored cytokine armored CAR-T may be more efficacy in clinical practice.
Any more questions?
I have another question. If there is nobody to ask, I have another question. Do you think we need to apply the same principle of activating the T cells by transplanting non-specifically non-matched or fully mismatched T cells from an allo donor during the induction of patients with acute myelogenous leukemia, like the old what you call it, leukapheresis transfusion protocol with AML induction therapy, so that you can induce an initial transient chimerism and little cytokine storm and targeting of the abnormal malignant cells by the transfused T cells. It's a principle proving experiment.
Oh, sorry, and would you like to repeat your question? Sorry.
The principle of armoring the T cells, but not from the same patient, from an allo donor during induction phases of acute myelogenous leukemia or any other leukemia, so that you can induce a form of a transient chimerism where the allogenetically or allogeneically transfused T cells may be able to induce a transient chimerism and some control of the malignant cells in the recipient.
Yeah, I think for the allogenic, now we will study such as cytokine as in armored CAR T in the autologous CAR T cells. And we also induce the allogenic CAR T and some the patients, and we will treat it as a SLE or the solid tumor. I think just like the strategy, cytokine enhance function, and also can be used the allogenic CAR T cell. And in the SLE patient treatment, we don't use the lymphodepletion chemotherapy, just like the cytokine enhance the function. And for such the treatment, I think that also we can reach the complete remission. So in future, so I think the cytokine enhanced armored CAR T can be used the solid tumor, because it's the solid tumor we can overcome such as the barriers of the solid tissue, tumor tissue. So I think that in future, more and more patients can be used such as a strategy.
Thank you. Thank you for the answer. Any more questions? Thank you, Dr. Hang, for this comprehensive presentation and answering the question. It's time to go to the next speaker.
Thank you.
It's my pleasure to present Dr. Guy Saviggio. He is a principal investigator of laboratory for stem cell epigenetic at the Institute of Research in Immunology and Cancer, University of Montreal. He is also practicing hematologist at Maisonneuve Hospital within hematopoietic stem cell transplant program, and he is a co-founder and chief scientific officer for two Canadian biotechnical companies focusing on the stem cell expansion and rejuvenation. He is leading a program that identified previously unrecognized mutation and developing of new therapeutic strategies, predictive biomarker of the drug response, and molecular tools that contribute to personalized treatment for approach AML. Dr. Saviggio will going to present the use of expanded cord in patients with high-risk malignancies.
Good morning, everyone. Can you hear me well?
Yeah, clear.
Okay. So I will share my presentation. So I wish I was with you guys being in the cold Montreal this morning. So can you see my presentation? I guess not. What about now? You see the presentation? Okay, so today I'm going to give you some of our recent data on the expanded cord blood grafts with the UM171 molecule. Much of this was recently presented at the EBMT, as you know, in Madrid last March. So I want to introduce to you the important notion of young balanced HSCs versus old myeloid HSCs, which I think are truly the next frontier in stem cell transplant. So when we talk balanced HSCs, I think we talk about the ideal cells. They provide maximal lymphoid output. They confer epithelial rejuvenation, and I'll come back to this. They provide maximal functional innate and adaptive progeny, and they are in young tissues, young donors, including cord blood. Now, the MyHSCs or myeloid restricted HSCs have little to no lymphoid output. They develop as we age. They disfavor tissue regeneration. They are pro-inflammatory, and they further contribute to aging, and they're in older tissues. So a notion which is not very well known, but quite well accepted in basic science now, is the notion that the balanced HSCs provide good lymphoid progeny, which include these innate lymphoid cells, in particular the type 2 and the type 3s, which are tissue lymphoid cells with no T cell receptors. They're like NK-like, and these cells are extremely important for producing the key growth factors for several tissues, notably the gut, the thymus, the skin. And in absence of these ILC3s, you actually get failure of these epithelial cell rejuvenation. So in some ways, our young HSCs contribute to aging or to prevent aging of our epithelial tissues and repair. Now, the MyHSCs, they lack this lymphoid development potential and they disfavor regeneration, leading to tissue compromise. Now, HSCs are prone to several other problems besides the myeloid bias. They're bad in DNA repair. They lead to clonal hematopoiesis and inflammation, and they have reduced renewal capacity and exhaustion. Now, this cartoon that I made tried to summarize this. So as we age in vivo, or if we accelerate aging by transplanting cells in patient or giving them chemotherapy, they become, of course, MyHSCs. But also when we do ex vivo proliferation, for example, during gene therapy or during expansion, we go into these accumulation of myeloid or MyHSCs. Now, you all know that if we use older donor, we get, for example, if we use a 50-year-old donor versus a 20-year-old, this will lead in unrelated transplant in a reduction of overall survival, which is quite important. And this is why young age has now become a key criteria for transplant physicians, in addition to HLA matching. Now, the accumulation of MyHSCs leads to clonal hematopoiesis. This gives you chronic inflammation with poor immune reconstitution, thymus involution, cardiovascular disease, and progression of organismal aging. And just a quick reminder, CHIP is quite frequent post allo transplant. And I think this is a clear reflection of donor age. For example, some recent studies have shown up to 40% CHIP relatively early post-allo of peripheral blood stem cells or bone marrow versus 3% for young graft like cord blood, for example. So HSC aging is under the control of key epigenetic marks. I've only put that slide here for reference, but importantly, there are key and well-known histone methylation and acetylation, which are lost upon aging, and these results in the accumulation of MyHSCs. Now, I just want to give you an example from our laboratory here of some key epigenetic marks that are rapidly altered, and this is after in vitro culture of only 3 days. By day 3, for example, K4-ME2, so methylation of lysine 4 of histone 3, is rapidly reduced. Likewise, K27 acetylation. So, another important notion is that these epigenomes that are aged, they persist in young recipient with old graft in time, even after 30-some years. So your graft always remains, epigenetically speaking, older than you, and likewise, young grafts in old recipient also keep their young epigenetic marks. So the question then becomes, how do we transplant the youngest cells? And one possibility is to use cord blood, because cord blood has a lot of balanced HSCs. But as you know, and as you well know, it's associated with very important issues. So low cell dose leads to delay engraftment and high non-relapse mortality. Low cell dose leads to graft failure, and low cell dose negatively affects HLA matching, which on its own increases NRM in cord blood transplantation. However, cord blood has numerous benefits, most likely because it has an important number of balanced HSCs. It appears to be the most potent graft in very high-risk disease. There's now numerous papers in the last 2 years showing that cord blood transplant has the lowest rate of relapse in high-risk and very high-risk disease. It's got extremely low incidence of chronic graft-versus-host disease. The cord are rapidly available, and they have low risk of viral transmission. So the question then becomes, if expansion could fix the low cell dose, how do we make sure that we don't shift the cells from a balanced statute to a my-restricted statute? And so therefore, we thought that we need to understand the mechanisms that prevent the development of myeloid-restricted HSCs. My lab and many different labs over the last 30 years have focused on a lot of prospects for this, and we have identified about 14 years ago and developed a small molecule called UM171, which appears to have these properties. So this is the optimized molecule, which specifically focuses the most primitive cells using in vivo experiments. And if, for example, I go back to these epigenetic changes that you rapidly see in a 3-day culture without the molecule, when you introduce UM171, you in fact correct these epigenetic marks both on the methylation and the acetylation. So we also learned that when we take CD34 positive cells, this is single cell sequencing, the red dots represent the HSCs of the stem cells. If we look at them with a 7-day treatment of UM171, you get a massive expansion, but you also get expansion in blue, quite important, of common lymphoid progenitors, LMPPs, but you also get other cell types, such as a very important set of mast cell precursors and dendritic cell precursors. So these are not normal grafts that we're providing to the patient. And these grafts, we call them rejuvenated because they have a huge increase in the content of functional T cell precursors, leading to thymus rejuvenation using human cells into NSG mice. Now, not only do these grafts provide better T cell recuperation and regeneration in vivo, as you will see, but they also have an important number of CD34 plus, CD86 plus cells that behave exactly like NK cells. They're killer. And if you sequence them, you see that they have an enhanced cytolytic score. So you actually give these patients about 1 to 2 million cells per kilo of these killer cells when you transplant them. And importantly, we also see in mice, this is mice reconstituted with UM171 treated cells, human cells, you see an important accumulation of mast cells in their tissue following transplantation in the spleen, the liver, and even in the peritoneum. And that's quite substantial. And as we know, mast cells are important preventers of gut graft versus host disease. So how does the molecule work? Well, it took us about 10 years to realize that this is a molecular glue degrader between a new E3 ligase complex with the adapter called KBTBD4. So it works a little bit like thalidomide, if you want, as a molecular glue, and this CoRES complex, which is composed of 2 important chromatin-modifying enzymes, HDAC1 and LSD1. And actually, when you treat cells, CD34 cells, with this molecule, you get a rapid degradation of this epigenetic complex. And this explains in part why we see the correction of the epigenetic marks. We also recently published in Blood that this complex is also degrading c-MYC, and especially chromatin-bound c-MYC, with important impact, as you'll see on this slide. So these are actually, each of these dots represent mouse that are reconstituted with human cells treated for 7 days ex vivo with UM171. And this is the impact of the treatment. So DMSO treated, UM171 treated. Now, if you put a non-degradable form of MYC, which is called MYC-T58A, into these cells, in the absence of UM171, it doesn't make a huge difference. But in the presence of UM171, you lose the impact of the molecule. So you need to have degradation of the molecule. But most importantly, not only do you lose the impact of the molecule and you're back to standard level, but on top of this, shown here in red bars, this is human reconstitution of myeloid cells, and the blue bars are human reconstitution of lymphoid cells. And essentially, now by making a non-degradable MYC, you prevent UM171 from giving you these happy balanced HSCs, and they all become unhappy MyHSCs. Now, let me leave the theoretical work and come into clinical trials. So we've now transplanted more than 125 patients over the last 10 years with these grafts. And I will show you two important clinical trials. One is our phase 1/2 for patients that lack an adequate donor. And the other one is our phase 2 called 002004 that were just terminated a few weeks ago. And these are for the very high risk ALL, AML, and MDS, 60 patients. So how do we do these transplants? We take a cord, we ship it to Montreal, we separate the CD34 cells from the T cells, we freeze the T cells, and we introduce a UM171 molecule for 7 days. And then we wash off the molecule and the cytokines, and we freeze the bag, and then we ship it to the transplant center. So the transplant center gets 2 series of bag, the T cells and the expanded CD34 cells. So it's a single cord transplant. It's a 7-day expansion procedure. Now, the first trial was done here in Canada under the leadership of Dr. Sandra Cohen at our center, Maisonneuve-Rosemont, and it was published in Lancet Hematology. It was for patients lacking an HLA identical donor recruited between 16 and 18. And the primary endpoint were mostly feasibility, safety, but we wanted to find out what is the smallest cord blood that will achieve prompt engraftment with this technology. So the goal was to lower the non-relapse mortality associated with cord blood transplant by shortening neutropenia and by HLA matching these cords better to the patients while maintaining the advantage. We wanted to make sure that we maintain the advantage of cord blood transplants, namely low relapse and low rate of chronic graft-versus-host disease. Of course, we were a bit worried because of what I've shown you before, that graft-versus-host disease might be enhanced. So these were relatively high-risk disease patients. So 23% had undergone a previous transplant, 18% in CR2, 14%, 3 patients in active disease at the time of transplant. Now, importantly, because we could use small grafts, because we can expand them, 80% of the patients had 6 out of 8, whereas normally 80% of our patients using a standard size cord are transplanted with 5 out of 8. We transplanted 22 patients with single cord in this phase 1. Median time to 100 neutrophil was 9 days, 518 days. Our non-relapse mortality at more than 5 years was 4.5% in this trial. This is now data that has matured for 5.5 years with OS, PFS, and GRFS data, which is quite spectacular, as you can see. In these patients, they were rapid lymphoid, so almost 100% lymphoid reconstitution and myeloid reconstitution by day 14. They were giving high CD4 cell counts of 200 by 3 months. And importantly, when you compare these to standard transplants, in this case, it's our MUD-ATG in Canada, they were doing better than our standard MUD. Now, because of this fast neutrophil and monocyte recovery, we had very low rate of febrile neutropenia, with many patients not developing fever at all during these transplants. This is compared to our control cord blood transplant in our center during the same period of time, to bone marrow and to mobilize transplant. And as a result, we had a strong reduction in the incidence of severe bacterial early, but also viral infections late. Most interestingly, we had very high initial NK cell counts compared to standard cord transplant. But when we look at the T cell repertoire diversity, the TCR repertoire diversity, in early post-transplant, in blue, it was less than our standard cord, probably because we use smaller cord, and at that time, the T cell immunity comes from the unexpanded fraction. But as early as 6 months and 12 months post-transplant, we had a strong and significant increase in T cell repertoire diversity, very likely because we do not compromise the balanced HSCs, quite the contrary. We appear to expand them and give them better lymphoid output. Now, this is a scatter plot. Each dot represents a cord blood in a Canadian cord blood bank. And what you can see in blue is the 4% of these cords that would be available for a 70-kilo adult patient here in Canada and in the US under the current criteria. Now, because we use expanded cord, and we demonstrated in this first study that we can use 54% of the cord in a bank, and therefore we switch the profile of matching of 5 out of 8 to 6 out of 8. And right there, we think this contributes to the reduction in non-relapse mortality. So we conducted a CIBMTR and a EBMT match pair analysis that was published a couple of years ago, and basically compared to cord blood, looking at non-relapse mortality. In blue is the control, and in red is the UM171. This was significant. And for match unrelated, it had a trend for significance in non-relapse mortality. Okay. Now, we saw very similar results with the EBMT trial. So what we concluded from this first trial, for patients who we felt lack an HLA identical donor, is that we have access to smaller, better HLA matched cord. These graphs seems to be safe with low transplant-related mortality. We've significantly reduced complications associated with cord blood transplant. We preserve the benefits of cord blood transplant, namely low chronic graft versus low disease. And what was very interesting and aligned with the fact that we seem to have low recurrence in high-risk patients is that we appear to have cured some very high-risk patients in this first trial, including a couple of guys that had refractory T-ALL that were essentially rescued. So because of this, and because of these safety results, we wondered if this was potentially a perfect graph for people that are at very high risk acute leukemia and myelodysplasia. So before going to my last few slides on this phase 2 trials, we just got a few months ago a conditional approval in Europe for patients that lack a suitable, readily available donor. Typical case, for example, is unacceptable health status of a donor in the case of an urgent transplant, high titer HLA antibodies against the donor, inability to identify a cord blood of appropriate size. And I just wanted to highlight this for you guys. Now, moving to my last couple of slides on the results of a phase 2, one in Canada, 002, and one in the US and part of Europe, 004. Now we're moving to these very high-risk patients. 60 patients in total, and primary endpoint was relapse-free survival at 1 and 2 years, and non-relapse mortality. This time, we were willing to accept higher non-relapse mortality because, as you know, these patients, whether they're P53 AML or second allo early relapse, they come infected into transplant. And we this time preferred to mismatch them thinking that these guys are so desperate that maybe we would get more graft versus leukemia effect. But as you will see retrospectively, 5 out of 8 with these grafts doesn't make a difference versus 6 out of 8. Now, let me just show you what kind of patients we're dealing with here. This is the patients from Canada. And in yellow is what the primary PI has highlighted as complicated patients and very high risk. For example, AML, complex karyotype P53, MDS, very complex cytogen, AML, complex karyotype P53, AML relapse 3 months post-allo, MDS, complex karyotype, double allelic P53. I can go on and on, but you see that I'm not talking your standard transplant patients. And I added the stars on what the PI did not add because 5 of these are in fact post-allo. So these are the worst of the worst patients that you can get. So 60 patients in total, 002 trial 30, 004 30. These are the patient characteristics. Now our median follow-up is 25 months and all patients have completed the 2-year follow-up. Overall survival is shown here at 64% 2 years, relapse-free survival at 60% for these patients. If you look at the median, which was 43, below median, the overall survival is 80%, relapse-free survival 78%. Transplant-related mortality was higher in this population, 15% at 12 months, 20% at 20 months. Look at the relapse rate, 13% at 12 months, 22% at 24 months. I remind you, this is a very nasty population. Non-relapse mortality for the median and below median is at 0%. Okay. Now we wonder what does affect non-relapse mortality. Essentially, there was nothing significant, but there was a trend for prior transplant and being at CR at transplant, nothing spectacular. What factor appears to be affecting relapse? There we had a significant factor, and it was the presence of T-cell chimerism at day 14. Below 95% in red, these are those that relapse. And if there's a couple of papers in standard transplant that also suggest that this is a risk, and that's the best we could see with this. And aligned with this, if they had acute graft versus host disease, there was a trend for protecting against relapse. So acute graft versus host disease grade 3 to 4 was at 20%. All of these patients respond extremely well to glucocorticoids, and chronic graft versus host disease, moderate to severe, was in the range of 7% at 24 months. So in summary, what we can say is that UM171 expansion readily identifies the poor quality grafts. About 2 or 3% of the cord will not expand, and they usually have key issues, so you don't transplant these. It allows for transplantation of smaller, better HLA match cord. We have nearly 100% platelet and neutrophil engraftment, low frequency of severe viral and bacterial infection. NRM and GVHD is very low, especially for the 6 out of 8. Relapse rate is low in these high-risk disease, and clinically significant GVHD is minimal. So again, first indication for approval was this, what we call the donorless. So, and you guys will actually have access to this, I hope, shortly for patients lacking a suitable, readily available donor. And we're currently working hard with the FDA to bring this into a phase 3, but into early approval for the high-risk patients. Phase 3 design is shown here, but my time is running. Essentially, there's going to be 100 patients per arm. We hope to open the phase 3 soon in Canada and in US and in Europe. And I would like to conclude that the UM171 molecule, through the mechanism of action that I showed you, amplifies balanced HSCs and leads to their rejuvenation. It generates safe and effective transplants, especially for these high-risk patients. And these are the people who contributed to this, in particular, Dr. Cohen and Filippo Milano. leaders of the 002 and 004 trial. Thank you. Yeah, that's a very thank you for your question, and it's a very important point. So, because I'm a transplanter myself, and this company has developed the product from transplanters, we're extremely aware of this issue. And so, just for your information, it takes about 3 weeks from the order until you get the frozen products into your hospital. We've delivered this in US, in Europe. Um, and it's relatively straightforward. We actually did our first commercial patient this week in Germany. So the product, we know that selecting cord is not easy. So because of this, we help the clinicians to select their cord. We've developed expertise, obviously, in selecting appropriate cords from appropriate banks. We take care of shipping the cord here and shipping it back to the transplant center. So your question is at the very center of what we do. We also help the clinicians manage these patients initially. So we offer them, one of us is on call to help them. And I honestly don't expect any issues there.
Dr. Said?
I have a question. Thanks a lot for your presentation. My question regarding this platform, the UM171, is this disease specific? So it did work for patients with heme malignancy, maintaining the durable GVL effect and enhance the immune reconstitution post this expanded cord blood. What about other non-malignant conditions like immune deficiency, a metabolic disorder? Should we change the platform or any other thoughts?
Thank you for your question. So obviously, we've aimed for the very high-risk patients initially because we felt it was an important need, and we wanted to see long-term effects of these grafts before moving into benign disease. So the first trial has now a median follow-up of more than 8 years, and we've never seen, secondary neoplasia. We've never seen secondary aplasia or loss of the graft. And by the way, for these patients who have relapsed, when we give them chemo, they behave as if they were never transplanted, so their counts recuperate very robustly. So we've done only one aplastic anemia patient who had no donor, and it was very successful with rapid take. We also did a trial in multiple myeloma. Believe it or not, one of our transplant physician here in Canada does allos for multiple myeloma with very good success. And we used that trial to try to see what was the optimal conditioning regimen for outpatient transplant, which we did. And so I think long answer to your question is that we now are in a position where we could start to do benign diseases like aplastic anemia, immunodeficiencies. We know the prep regimens that the low intensity prep regimen that are compatible with these grafts, but we haven't started. There's a couple of investigators, one in Brazil, Dr. Caledo, who wants to do a phase 2 trial of a plastic anemia patient with these grafts versus standard of care.
Hi. I have a question related to the homing mechanism of the cells after manipulation with different molecules, especially those who may manipulate the differentiation amongst the myeloid versus the lymphoid ones. Referring back to the studies by Tanya Papanou from Seattle and Catherine Verfay from the University of Minnesota before leaving the States, it was clear that many of the stem cells, the steady-state bone marrow versus mobilized stem cells versus cord blood, may have different expressions of cytoadhesion molecules and that may actually direct their homing percentage and sites to different areas. Do you think your molecule may also affect the homing mechanism? That's why preserving some of these cells so that they can home directly to the bone marrow instead of going to home first to the MPS of the monocytic phagocytic system before they go back again to the bone marrow, or there is only direct effects on the epigenomic phenomenon?
That's a very important question, and thank you for asking. We haven't done systematic homing studies in mice, with the kind of rigor of the people that you mentioned have used, including Catherine, to really directly address this. Nonetheless, we have looked at the immunosurfaceome of the cells exposed to the molecule by mass spectrometry, and we do see an upregulation of CD90 itself, of CD201, and of one specific integrin involved in homing, which we published called IDGA3A. And however, we haven't functionally assessed the importance of these guys in homing per se, but when we downregulate their expression by genetic means, we do see a compromise in these grafts. So it wouldn't surprise me that there is something additional about homing. I went fast, but you also saw that at least in mice, I can't do this in human for obvious reasons, but at least in mice, we do see homing of these mast cells into solid organs, including the liver, which is quite impressive and surprising, actually. And I don't know for how long it lasts in mice, but we've looked at it in the early phase post-transplant, and it's quite spectacular.
Thanks a lot, Dr. Sfaggio. We'll move now to the third presentations and the last one for the sessions.
Thank you all.
It's my pleasure to introduce Dr. Valera Marina Bintu. She's a hematology specialist with over 15 years of experience in hemoglobinopathies and rare congenital anemia. Her expertise spans management in thalassemia and sickle cell disease, and diagnosis and management of congenital anemia and iron metabolism disorder. She's currently involved in the preparation of patients with hemoglobinopathy for curative therapy and work at the hematology and cellular therapy unit of Policlinico San Martino Hospital in Genoa. She will present to us the definition of the clinical outcome for transplantation and gene therapy in thalassemia and sickle cell disease.
Good morning, everyone. I'd like to begin by expressing my sincere gratitude for the kind invitation to participate in the annual conference of Saudi Society of Blood and Marrow Transplantation. It's a pleasure to have the opportunity to contribute, even if remotely. Unfortunately, I am not able to be in person with you due to the current global circumstance. In this presentation, I will outline the clinical outcomes for gene therapy and allogeneic stem cell transplantation in thalassemia and in sickle cell disease, with a particularly focus on the challenges in defining these outcomes and the need for harmonization of outcome measures. Just a few seconds for my disclosure. So in recent years, curative therapies for hemoglobinopathies have been evolving very rapidly, and these include allogeneic stem cell transplantation as well as the newer approaches such as gene therapy. However, one of the main challenges in this field is the heterogeneity of efficacy endpoint used across different studies, and this makes direct comparison between studies quite difficult. And in addition, the available data come from different sources. Allogeneic stem cell transplantation data mainly derived from academic trials and international registries, while gene therapy data come from industry-sponsored trials. So for this reason, there is an increasing need for harmonized definition of clinical outcomes, especially now that commercial gene therapy are being approved, and in particular in the field of sickle cell disease. Let me briefly outline the pathophysiology of thalassemia and sickle cell disease. In thalassemia, more than 350 mutations can cause the absence or the reduction of beta globin synthesis, and this results in the accumulation of unstable alpha chains in the erythroid cells, leading to ineffective erythropoiesis and hemolysis. And clinically, this causes severe anemia, lifelong red blood cell transfusion, organ damage, and reduced life expectancy. So the main goal of curative therapy in thalassemia is a transfusion independence with adequate level of hemoglobin and the prevention of organ damage. In sickle cell disease, a single amino acid mutation in beta globin chains lead to the production of pathological hemoglobin, and when deoxygenated, it polymerizes, and this results in vaso-occlusion and hemolysis, leading to painful crisis, severe anemia, progressive organ damage, and reduces life expectancy. So, in sickle cell disease, the main goal of curative therapy is the elimination of vaso-occlusive crisis, normalization of hemoglobin, and correction of hemolysis, and the prevention of organ damage. In this comparative table of curative therapies, curative strategies, you can see some key aspect of hematopoietic stem cell transplantation and gene therapy. A major difference is that transplant uses allogeneic hematopoietic stem cells with the associated risk of graft versus host disease, while gene therapy uses autologous stem cell. There are also differences in engraftment timing, in disease control, and in long-term morbidity and mortality. Allogeneic stem cell transplantation can improve pre-existing organ damage and offers a more complete long-term disease control, while gene therapy provides short-term control disease but not complete correction, and long-term follow-up data are still limited. These are the traditional outcomes used to evaluate transplantation, and these include overall survival, event-free survival, graft failure, acute and chronic graft versus host disease, graft versus host disease, free relapse, free survival, that is a composite endpoint, and transplant-related mortality. However, one limitation is that these measures may not fully capture the clinical benefit in non-malignant disease. And for thalassemia, the outcome that better measure the efficacy of the procedure include transfusion independence, effective erythropoiesis, restoration of iron hemostasis, reduction of pre-existing organ toxicity, and improved quality of life. In sickle cell disease, important outcomes are elimination of acute events such as VOC, acute chest syndrome, and stroke, elimination of hemoglobin S, correction of hemolysis, eradication of vasculopathy, that is the real big burden of the disease, prevention of organ damage, and improved quality of life. For gene therapy, clinical trials reported these endpoints as a measure of efficacy in addition to safety. In transfusion-dependent thalassemia, the consensus endpoint is the transfusion independence, defined as weighted average hemoglobin of 9 or higher without red blood cell transfusion for at least 12 months for both gene addition and gene editing. In sickle cell disease, for gene addition, endpoint include a complete resolution of VOC, including severe VOC. For gene editing, endpoint include a period of freedom from VOC for at least 12 consecutive months and a period of freedom from inpatient hospitalization for at least 12 consecutive months. So this difference in definition in sickle cell disease clinical trials include variation in care setting, in duration of care, in treatment applied, in definition of acute complication, as shown in the table on the left from a recent report by Frangul and colleague. And the same report illustrates how different definition of vaso-occlusive events in sickle cell disease trial can affect the reported outcome, and depending on the criteria used, the same group of patients may be considered free from pain or not. And this highlights the importance of caution when comparing reduction or elimination of vaso-occlusive pain between trials, as differing definition can make cross-study comparison misleading. So, how can we measure the clinical benefit of this procedure? A key question is when we should evaluate the response, after 1 year, 2 years, 5 years. So defining the timing is crucial to ensure that the assessment is meaningful. And to measure benefits, we first need a clear definition of what it means to be free from VOC, including number of events, duration, severity, timing of hospitalization, treatment applied, and we should also consider chronic pain and differentiate it from other causes of pain. Improvement in quality of life is also an essential outcome, as it matters to most patients, and we should consider evaluate organ function, which can provide insight into the long-term impact of this therapy. And this is a very challenging area, but biomarkers can help us, offering information about chronic damage, such as the hemolytic phenotype. And several organ targets are therefore considered. An important point is the need of consensus on how organ responses are defined and the timing of evaluation, particularly for long-term follow-up, in order to better compare results across studies. This laboratory and instrumental assessment help identify and estimate organ damage. For heart, echocardiogram and 6-minute walking test, functional test for lung, blood test for kidney, such as albumin to creatinine ratio and the measurement of blood pressure. It's important also transcranial Doppler ultrasound in sickle cell disease until 16-18 years old, the MRI of brain, and test to assess the cognitive function. For the liver biopsy or MRI. So when we talk about a cure, we mean more than just fixing a blood count. It's about stopping clinical events, protecting organs, improving patients' quality of life, while making sure that the benefits are long-lasting and the treatment is safe. So this slide outlines the proposed core outcome domains for evaluating curative therapy. Survival is a key and remains a key endpoint, including overall survival and non-relapse mortality. Disease control can be assessed through evaluation of endpoints such as transfusion independence and VOC-free survival. Biological correction looks at laboratory markers such as fetal hemoglobin, hemolytic markers, chimerism for allogeneic stem cell transplantation, and vector copy number for gene therapy. And organ function is also critical, not only to monitor existing damage, but also to detect early change with measures including cardiac MRI, kidney and lung test, and patient-reported outcome capture the patient's perspective, including fatigue, pain, and overall functional status. So together, this domain provide a comprehensive view of both the clinical and personal benefits of these therapies. But a difficult question is how can we combine all these factors? Could we assign a weight to each of them and develop an overall score? This process requires careful evaluation based on clinical evidence to ensure that the score truly reflects the patient condition and can be useful for guiding therapeutic decision. There are also several challenges to consider. First, age-specific considerations are important. Pediatric patients, children, and adults may respond differently to curative therapy, both in terms of efficacy and side effect. For allogeneic stem cell transplantation, even after a successful transplant, the graft can fail over time, making long-term monitoring essential. For gene therapy, certain cell clone may become dominant after gene therapy, so again, careful long-term follow-up is crucial. And both transplantation and gene therapies carry a theoretical risk of malignancy, so ongoing surveillance is critical. And both therapies can impact fertility, so this must be discussed with the patient before the treatment. So when evaluating curative therapy, durability and late events are crucial consideration. Ideally, patient should be followed as long as possible, and this is important to capture long-term outcome. And registry-based monitoring is essential to gather comprehensive data. Long-term safety and sustained efficacy are particularly important to truly understand the benefits and the risk of these therapies over time. Here you can see the proposed EHA-EBMT assessment for short, medium and long-term follow-up for patients with sickle cell disease candidate to gene therapy. So, to move toward harmonization, several steps are needed. Consensus panel and expert working groups can help define priorities. Developing a core outcome set for trials ensure that all studies measure the same key endpoints. Uniform reporting guidelines makes the result more comparable, and shared registry data enable cross-study comparison, improving our understanding of treatment effectiveness and safety. So, curative therapies are evolving faster, very faster than our current outcome definition, which makes the harmonization, standardization process very urgent. A true cure should go beyond blood counts and include organ protection and durability over time. Harmonized definition across studies are essential to measure success, and long-term follow-up is not negotiable to ensure both safety and lasting benefits. So,
thank you, Dr. Binti, for your excellent talk. I think we have time for questions.
Any question? Okay, thank you, Doctor, for this comprehensive presentation, and we have no question here. We will conclude this session, and we will be back at 3:45 for last session. Thank you.
This is on?
Okay, assalamu alaikum. So now we reach the final session. It's the last, but by any means, it's not the least important session. We have 4 speakers. They are very distinguished speakers. We'll start with the first one.
So I have the pleasure to introduce first speaker, Dr. Badal Al-Ahmari. Dr. Badal Al-Ahmari is a consultant at the Division of Adult Stem Cell Transplant and Cellular Therapy, Department of Oncology at King Abdulaziz Medical City, Riyadh, Ministry of National Guard Health Affairs. He is also the chairman of the Blood and Cancer Research at the King Abdullah International Medical Research Center in Riyadh, Saudi Arabia. And Dr. Badr is going to talk about advancing chronic GVHD care from evidence to practice. Dr. Badr, please go ahead.
Right, Assalamu alaikum wa rahmatullah. Good afternoon, everyone. It's my pleasure to present about chronic GVHD today. I'd like to thank the organizing committee and thanks the Sanofi for the sponsorship. So as we know that chronic GVHD is one of the complications that happen post allogenic stem cell transplant. Is a syndrome that simulates, let's say, autoimmune diseases. It occurs in up to 70% of patients at different severity. The most common involved organ is skin, followed by mouth, liver, eyes, and others. And by definition, classic chronic GVHD can happen anytime. It depends heavily on the form of presentation and the kind of syndromic feature of the presenting symptoms and signs. We can diagnose chronic GVHD based on that, regardless of the timeline post-transplant. Risk factors, there are universal risk factors that is known for a long time to be associated with an increased risk of chronic GVHD, including mismatched donor transplant, mobilized peripheral blood stem cells, the type of conditioning regime, myeloablative versus rare reduced intensity, and the donor and recipient age. Chronic GVHD overall can be mitigated with the use of advanced and recent improvement in the GVHD prophylaxis, the form of in vivo T cell depletion. For example, data from 2 randomized studies showed that incorporation of ATG has resulted in significant improvement in the development of chronic GVHD, as well as nowadays the use of BTCY has been shown in at least 3 randomized studies outside the haploidentical setting showed there was an improvement in the graft versus host disease-free, leukemia-free survival rate for this by doing this intervention. Nonetheless, the non-relapse mortality post stem cell transplant is significant, and one of the leading causes for non-relapse mortality is actually GVHD. Chronic GVHD is a significant cause for non-relapse mortality, and it can account to up to 37% of all patient population underwent allogenic stem cell transplant, indicating an unmet need to control this, to prevent first, and second, to treat this kind of complication. Biologically, chronic GVHD undergo multiple stages. The initial phase is an inflammatory phase, where it really exerted through the innate immune response with the role of some cytokines that can play into this, followed by a cellular stage where the recruitment of the immune cells, different kind of immune cells, has been shown to implement in the pathobiology of chronic GVHD. The latest stage is the collagen deposition and fibrosis. So there are an impairment in the tissue repair associated with the chronic GVHD, driven primarily through the macrophages, the fibroblast, and some molecules such as TGF-beta. Mainstay of manifestation, so it can involve any organ, to be honest. I mean, chronic GVHD can be involved any organ, commonly skin, eye, mouth, and lung, one of the devastated complication of chronic GVHD or manifestation of chronic GVHD. So any form of fibrosis we can see in these organs. And the aim of treatment usually is to induce some remissions, although it's rare to induce, not really common to induce complete remission, especially for those who are relapsed, who are refractory to the steroid. But the main aim of treatment is to minimize or reduce the symptom burden, improving quality of life, and prevent further immunosuppressive, and with that you prevent the increased risk of infection. Well, we know that chronic use of immunosuppressive has been associated with increased risk of infection, metabolic syndromes, and chronic fatigue, reduced quality of life, and even increased risk of certain type of cancer. It has chronic GVHD has an impact, huge economic impact. There are some data from, at least from US, showing that 71% of chronic GVHD patients, they lost their income, and more than 50% they have to reduce their working hours, and around 1/3 of patients, they lost their job, indicating an unmet need. In terms of systemic treatment, if it is indicated, when it's indicated, usually we treat some patient with moderate and severe chronic GVHD. We usually do systematic treatment. And the standard treatment here is use of glucocorticoid, usually 0.5 to 1 milligram per kg per day. And this can induce remission up to 50% of patients. However, usually the course is prolonged and associated with increased exposure to glucocorticoid, and you know that with the exposure to corticoid, there is an increased risk of complication as well from the treatment. Assessment of response is very important after the use of with the initiation of steroid. So the definition of steroid refractory based on three things: whether they are refractory from the beginning for the steroid, or they are steroid dependent. So whenever you taper down the steroid to the minimum doses, then they will flare up again. And the third type of is the steroid intolerance. I mean, they are on steroid, they are responding nicely, but they developed a lot of complications. They could not tolerate the steroid. And this is based on the NIH criteria for response assessment. So what happened to those patients who met one of these criteria? Usually we start the second line. The standard second line now is the use of Jakafi or ruxolitinib, which has been shown in the REACH3 trial, a randomized study showing the superiority over the best available therapy, and it's our standard of care. We know that the prolonged use of steroid, as I mentioned again, associated with a lot of complication and reduced quality of life. And once patients pass the stage of the first line of therapy, usually the duration of treatment is around median duration is around seven months, and around 70% of patients somehow they will require a second line therapy, and that's indicating unmet need. And subsequently, this second line therapy usually has short-lived, and subsequently the patient will require a third line of therapy, which is required for up to 50% of patients. Options for third-line therapy is palbociclib. Palbociclib is a ROCK2 inhibitor, has been approved since 2021 for patient age above 12 and above with chronic GVHD who fail at least 2 or more lines of therapy. So we know that ROCK2 is a molecule that works in the downstream signaling of some cytokines and growth factors, and play a major role in phosphorylation of STAT3 that is associated with increased or expansion, development and expansion of the Th17. Th17 cells are well known and well documented to be mediator of GVHD. And also ROCK2 block the STAT5 phosphorylation, which is essential for the expansion and survival of regulatory T cells. Again, it's a cellular component that is well known to be preventive measure for development of GVHD. So it has a pivotal role in the pathobiology and progression of the chronic GVHD. So what happened with the use of palbociclib, which is the first-in-class selective inhibitor of ROCK2, that by blocking ROCK2, you will actually allow the phosphorylation of STAT5 that can lead to expansion of the regulatory T cells, and you'll block the STAT3. With that, you block the secretion of different cytokines, actually, not only IL-16, but also interferon gamma and IL-2 as well, and lead to control of GVHD. So based on pivotal trial, the ROCKSTAR study, which is a phase 2 randomized study where the enrolled patient of 12 years and above who had persistent chronic GVHD with 2 to 5 prior lines of therapy, they randomized patient into 2 different doses, 200 milligram once daily, 200 milligram BID, with the primary endpoint was overall response rate. In terms of patient characteristics, overall median age was 54. Median time from chronic GVHD diagnosis to enrollment into the study was 28 months. And median dose of prednisone was 0.919 milligram per kg. Severe chronic GVHD account for almost 70% of patients. 4 and more organ involvement account for almost 50% of patients. Looking into more than 48% of patients receive at least more than 3 prior lines of therapy, indicating heavily pretreated population. And the ibrutinib were used in 1/3 of patients, and another 1/3 they have an exposure to ruxolitinib, which was the standard of care at that time. So we have data for 1 year and the 3-year follow-up as well, which was showing equivalent overall response rate, which was the primary endpoint, which was met, indicating that there is a sustained responses for the use of palbociclib, and both doses were showing the same overall response rate, something around 74 to 76%. Majority of these responses are partial remission, which is something acceptable in this advanced stage of chronic GVHD. And again, the main focus is really to minimize the symptoms, decrease the symptoms of burden, and also the improve quality of life. Responses were actually achieved across the different organ involvement, with the upper and lower gastrointestinal system showing the highest response rate, including the mouth as well, and the liver. Talking about lung GVHD, the overall response rate was 30%. 17% of these responses were CR, complete remission. So patient who start the palbociclib earlier, they achieved more than 86% overall response rate. Patient with severe chronic GVHD, the response rate was something around 74%. Patient with multiple organ involvement or 4 or more organ also showed 70% response rate. So indicating that the responses were equivalent across different subgroup of patients. This is important. The median time for response was around 4 weeks. And this is something really significant for this kind of heavily pretreated patient population. And around 2/3 of patients, the responses were seen between 4 to 8 weeks. So if there is a response, you will see it within the first 2 months of treatment with the palbociclib. Looking to the secondary endpoint, which is the median duration of response among responders, has been seen and increasingly over years, compared by 1 year and 2 years, and up to 80% of responses seen. They were continuous. And secondary endpoint looking into the Lee score, showing that responses were improving compared by 1 year versus 3 years. In terms of steroid taper, around 70% of patients, they were able to taper their steroid, and 20% of patients, they were able to discontinue their steroid. And in terms of calcium inhibitor, after 3 years, 47% of patients, they were able to reduce the CNI, and 20% were able to discontinue the treatment. And looking into failure-free survival, at 3 years, account for 42% of patient population. There were 58 increase in the quality of life in terms of metrics for quality of life. And the most common symptoms seen were fatigue. Fatigue is a known symptoms associated with palbociclib. However, other toxicities, including diarrhea, nausea, something can happen, but it's really something that we don't see it in practice. And even the discontinuation rate is not that significant. For example, overall, around 21% of patients, they actually discontinue their treatment due to disease progression, and 13% only discontinue treatment due to the adverse event. Cytopenia, we don't see it a lot with the palbociclib. Only 1.3% of patients, they develop grade 3 or higher thrombocytopenia, neutropenia, and 0% for thrombocytopenia. As I said, 13% only they discontinue treatment due to adverse event. For the failure-free survival in the intention to treat population, there were 75% at 6 months, and more than 50% of patients at 1 year. So I'd like to go quickly over at least 2 cases that from the earlier, showing our earlier experience with palbociclib. And we'll start with this case. This is a 19-year-old male diagnosed with severe aplastic anemia. He underwent match-related donor transplant from his sibling, and because there was a mismatch in the kind of weight, we could not do the bone marrow harvest. So we did the peripheral blood for aplastic. Otherwise, our actual approach is to do bone marrow harvest for those patients. So he underwent the transplant using Flo-Cy ATG with the cyclosporin and MMF GVHD prophylaxis. CD34 dose was 8.4. He engrafted nicely, neutrophil and platelet, and he developed some complication immediately post-transplant, which he passed through this complication. He developed acute GVHD. His main issue actually was a compliance. He wasn't really compliant in cyclosporin, because we don't see this usually with aplastic anemia patient. We have a high successful rate in the aplastic anemia with the minimum GVHD, but for him, he wasn't really compliant to the use of cyclosporin. So he developed acute GVHD of the liver, and then he was started on a steroid, and that led to the induction of remission without the need for a second agent. And then 7 months post-transplant, he started to develop moderate chronic GVHD, mainly in the mouth and the liver, started in a steroid, led to some improvement of his symptoms. However, 3 months later, he developed progressive chronic GVHD with scoring 2 NIH based on the NIH scoring in the fascia, 2 for mouth and 1 for liver. And so we increased the dose of steroid again We add ruxolitinib, which is our standard at that time. Despite of this, after 3-month assessment, he still have severe GVHD with mild improvement in the fascia. So we offered him really ECP, but he did not really agree to do the extracorporeal photopheresis, although he lived in Riyadh, so logistically was okay for him. From our side, was fine to do it, but he did not want to have a central line again. So he started on sirolimus in addition to the combination therapy, but again, he did not improve, and actually his fascia progressed a little bit. So we started palmocidal at that time. It was non-formulary, and we started palmocidal for him. And after 2 months, after starting the palmocidal, after 3 months, there was a significant improvement in his NIH score, mouth down to 1, and fascia from 3 to 1. Actually, the first response, we see it within 4 to 5 weeks. He started to move his wrist joint, and his range of motion improved significantly. So he's now almost 3 years post-transplant, 2 years post-diagnosis of chronic GVHD. He has actually more than 18 months on palmocidal now. Fascia 0, very, very, very minimum mouth finding, but he's completely asymptomatic. So I would say that he's almost achieved complete remission from his GVHD standing view. The second case is a case for one of my colleagues, which is really an interesting case. This is a 43-year-old female diagnosed with acute myeloid leukemia, translocation 821. She had also trisomy 4. She has also c-KIT mutation. She was treated with 7+3, and day 28 showed 8%. She was treated in another institution. It was 8%. Then subsequently she was started on AZA venetoclax. She received 2 cycles. Still she has bone marrow showing 10 to 15%. She was referred after that to our center for consideration of transplant. We induced her with FLAG-IDA. She developed some complication, and she did not really achieve good responses. Then we use high-dose RSE with gemcitabine azogomycin without significant response. Then we end up giving her MEC. She responded nicely to MEC, and she went into haploidentical transplant for her brother with the TBF reduced intensity conditioning regimen at that time from peripheral blood with BTCY, MMF, FK, GVHD prophylaxis. She had some complication, infectious and non-infectious complication post-transplant for someone who is heavily pretreated using haploidentical, and the use of TBF as well was associated with multiple complications. Within the follow-up day 60 bone marrow, she was in remission. There was 0.2% flow cytometry, by flow cytometry showing clearly leukemia-associated positive blast. So she went into another 2 doses to do 2 doses of donor lymphocyte infusion, which resulted in achievement of remission, but she developed, unfortunately, GVHD. At that time was grade 3 acute GVHD, skin, upper and lower gut, treated with the steroid, but she was refractory. She received ruxolitinib and ECB, which is our standard for any gut GVHD. We immediately moved from steroid into ruxolitinib combination with ECB, if possible, in terms of logistically and others. So
recording stopped.
Combination of treatment, and she achieved complete remission with the use of ruxolitinib and ECB. So 10 months post-transplant, she presented to the clinic with the new symptoms of progressive shortness of breath, and evaluation at that time showed that she has chronic GVHD of the lung. She scored 3 based on the NIH score. The FFV1 was very low. We started our standard protocol, which is FAM protocol, with 1 milligram per kg of prednisone, and after 1 month there was only mild response. Then we started her on ruxolitinib, which is our standard second line for this for chronic GVHD. There was a plan to restart ECB, but she refused. At that time, she declined that. This is her picture. You can see here clearly the air trapping on the expiratory phase of the CT, and you can see the FFV1 is very low at 29%. Her mouth symptom resolved, but lung is stable with some SOPs, FEV1 very low. We thought that she will keep progressing, so we added palmociclib at that time. And after 3 months of palmociclib, she showed actually an improvement. This is something we don't see it usually at this stage of lung GVHD. She showed actually improvement, and there was an improvement even by like symptoms and by number. Her FEV1 went up from 29 to 37%, and steroid and ruxolitinib was tapered nicely, and now she's almost 1 year post palmociclib initiation. She's off other immunosuppression except the FAM protocol, and she's maintaining on palmociclib. 0 admission since the initiation of palmociclib, and now her lung function is plateauing without any significant symptoms. So this is what I would like to share with you, and happy to take any question. Thank you for listening.
Thank you, Dr. Badr, for this excellent presentation and keeping on time. So we have time for one question. So if there are any questions, please raise your hand.
So if there is no question, Dr. Badr.
Thank you, Dr. Badr, for your great presentation. Well, my question is about fibrosis, especially in late stage of chronic GVHD. Do you think it is reversible or mainly manageable?
Can you raise your hand? We don't know. Where are you?
Okay. Yeah, so usually for lung GVHD, usually it's not reversible based on the experience with other anti-GVHD treatments. So once fibrosis happens, usually unlikely to reverse the fibrosis. We don't have strong evidence that any agent can reverse the fibrosis of the lung. However, we've seen some data that there can be some improvement in the PFT by numbers of the chronic lung GVHD with the use of palmociclib.
Thank you.
We can take one more question if there is any other question.
No more questions, Dr. Badr. Thank you. So we'll move to the next speakers. Dr. Aid Yahya. Dr. Aid, he is adult hematology and stem cell transplant consultant at King Abdulaziz Medical City, Riyadh. Dr. Aid will focus on, he is a focus on myeloproliferative neoplasm and clinical research. He will talk about what are the current common approach to treat CML. Dr. Aid, floor is yours.
Salam.
Before Dr. Ail starts, there are missing keys in an SSBMT bag. So if you find these keys, return them. Afwan, before Dr. Ail starts, there are missing keys for someone who left it in the SSBMT bag. So if you find this bag or accidentally took it, please return it. There are keys for somebody here in the audience. Thank you.
Assalamu alaikum. Thank you for the invitation, and also I'm going to take the chance to thank the organizing committee for giving the MBN more attention. So probably this is the first session you have, like I think more than 3 or 4 talk about the MBN. So I'm going to covering the CML, and there is no disclosure to be discussed. So CML is a malignant clonal disorder of hematopoietic stem cell, is leading to increase the number of the mature cells, but they are dysfunctioning. The common age is between 40 and 60 years. However, in Saudi Arabia, we have younger patients with the CML. It is coming from the translocation between chromosomal 9 and 20, BCR-ABL, and end up with a gene called BCR-ABL, which increase the cell proliferation and decrease the apoptosis. So under normal condition, the autoregulation of the ABL occur when the myristoyl group at the N-terminal, which is the blue one here, of the ABL1 bind to the myristoyl binding pocket and make the ABL inactive. So all what we have now as a treatment for CML is focusing in the kinase domain, either as ATP competitive or that's one that can bind to the myristoyl bookend and preventing the mechanism of the CML. So once you diagnose CML, so CML is diagnosed either through the family medicine or even in the internal medicine. So usually they present asymptomatic, and they came with most likely lift shifting. And there are three phases, which is the chronic acceleration and the blast. Acceleration is not anymore in WHO, but still in ICC. And just show you here without treatment, like if patient diagnosed with who have chronic phase, they have 5 to 6 years before progression to the acceleration, even without treatment. And we have like up to 9 months for acceleration to move to the blast. So this is a nice paper. It's showing us that the leukemia ranks as the 5th among the most frequent cancer in Saudi Arabia. And the CML is more prominent, which is this is also interesting in younger patients in our population. We see those 19, 20, and above who have a CML. And it is more common in male and female around 44, and 7.2 is the mortality rate amongst the Saudi leukemia patients. So this for all leukemia, not only the CML. CML is the most common between the leukemia patients in Saudi Arabia. So once you diagnose CML, then you need a prognostic score. We have 3 validated scores. The most common used these days is the last one, the European ELTS score. And SOCAR still used, but most of the old trial or study we're using the SOCAR score. Why we need this score? This score is helping us also in the decision of the treatment or choosing the target therapy. So I'm just showing you the survival outcome before in the impact of the TKI era. So clearly this target therapy, the introduction of the targeted therapy radically altered disease progression. The cumulative incidence of blast crisis dropped dramatically for patient who start for the patient with the TKI when you compare with the old protocol, which is the chemo or combination with the interferon. And even those who's in the blast crisis, the survival, you can see the pre-imatinib and the post-imatinib. In the pre-imatinib, the median survival around 4 months. And in that study, around 700, the one on the right side, around more than 700 patients. Before the era of imatinib, around 600 died. And when you compare with the imatinib era, is around just 47 who died. So what about the survival with the era? The 5-year relative survival with the TKI era is around 94 patients. And even the life expectancy almost normalized for the CML patient. This is a data from the Swedish CML patient, and regardless of the age, regardless of the gender, the life expectancy climbed down since 1970 to reach almost the normal population with the TKI. So once you diagnose the CML, then you have to start the therapy. So what we have these number of target therapy. So we have imatinib as first generation that came at 2001. Then we had the second generation, the dasatinib, neratinib, and also the third generation bunatinib, which is used only the second line. And in 2021 we start to have asciminib approved as the third line. And in 2024 we have asciminib as first line also approved. This is the selectivity of these target therapy of the kinase. The more red spot is the more blocking of the conformation of the tyrosine kinase. The more red spot, the more result. I mean the good response, but more side effect. This is the drug available and all approved as first line at the moment, apart from the bunatinib. And we will go through them quickly. So we have the imatinib. Imatinib is still working drug. The first TKI approved is simply 1 tablet a day, taken as pill with food or without. So regarding the quality of life, it's not as much. Regarding the side effect, is mainly diarrhea, nausea, muscle pain, and usually the patient, if just continue for 1 month, this symptom will be much improved. So usually we ask patients just we support him during the first month until the body tolerate. I think fluid buildup is a concern, and clearly there is no cardiac toxicity with imatinib. So that's why most of us, we like imatinib. Dasatinib is predicted to bind to multiple conformation of the ABL kinase, and is overcome the resistance that noticed with the imatinib. The side effect, the simple side effect like imatinib, nausea, vomiting, muscle pain, and again, usually we ask patients to continue on it, and and we support them, and most of them they adapted. However, I think the build-up fluid is more common, mainly the pleural effusion with the dasatinib. Regarding cardiac toxicity, is not that much with the dasatinib. And however, though I think this is not only the side effect. I have patient who's like young, 20 years old, and I have been following him for a year and a half. And at the beginning, he was just coming without wearing a cap. And then after 6 months, I noticing him wearing a cap. I ignored this in the second visit. Then I asked him why. Then he take the cap. He lost his hair. He has alopecia. I never asked him. I never counsel him for that. Definitely, there is more side effect, especially in our younger population. Nulatinib is another TKI. It has higher affinity. Again, is overriding the resistance developed with the imatinib. However, look how we use the nulatinib. So if you're going to take nulatinib, it's twice a day. You need to be fast 2 hours before, 1 hour after. So over the day, the patient need to fast for 6 hours. And I think this is going to impact the quality of life. However, it's a good drug for controlling the disease. The side effect, again, nausea, vomiting, the rash, it's happening, but it's tolerable. But the fluid buildup, it is still there, is less than dasatinib, but is there. And I think the other side effect is the cardiac toxicity. We see it with the nulatinib. Again, the electrolyte disturbance and the pancreatitis is a risk there. Bozatinib is another TKI. Just to point here, the bozatinib is not inhibit the domain mutation T315. And why I'm mentioning that, because asciminib, when is approved according to a simple study, they compare asciminib versus bozatinib. Asciminib is working against T3, but bozatinib is not. So bozatinib is taken with food once a day. Unfortunately, I mean, the common side effect is the diarrhea with the bozatinib, and the optimal dose is 500, and I think most of us rarely reaching this dose, so we end up with 300 or 400 because of the diarrhea. Bonatinib is multi-target kinase inhibitors. Bonatinib has a unique because is overcome the resistance that coming from the T315. Bonatinib, again, 1 tablet is taken with or without the food, and I think the common side effect, the concerning side effect is mainly the cardiac toxicity or the vascular toxicity events and the blood pressure. That's why when we use it, we become more concerned regarding this, especially in the elderly and those with the cardiac toxicity. Asciminib is allosteric inhibitor, so is block the myristoyl pocket they talk about in the first at the early. It is taken as either once a day or twice a day, but the dose should be 80 in total. And again, you need to fast an hour before and 1 hour after. Regarding side effect, nausea, diarrhea, again, all manageable. Upper respiratory tract infection or symptoms that look like upper respiratory infection, especially when at the early use, it's known to, it may disturb the lipid profile and also can cause hematological toxicity like other TKI. So this is the landmark study for the imatinib, dasatinib, and nulatinib, and all did show clearly there is significant major molecular response with these drugs. This is the base study for the bonatinib. I'm just going to show you the green column. You can see how significant bonatinib, how significant bonatinib can get the patient to the MR4 when you compare with the other. And here used after the first line. However, ponatinib, I think the side effect is the more concern, and the side effect mainly coming with the dose 45 milligram. So most of the approach we follow is we start 45, and when we get the BCR-ABL less than 0.1, we start tapering the dose down until 15 milligram, and you can see with the 15 milligram, the side effects is much less. Here is just showing you the dark blue is the percentage of the patient with the BCR-ABL less than 1, and the light blue is the incidence of the side effect. You can see when you go with the dose down, you start to have decrease those who have a good response. However, the side effect become much less. So before the asciminib era, so we have 5 TKI. Around 5 TKI, high rate of response, decrease the transformation to the acceleration of blast, nearly normal life expectancy with these drugs. And so why we still thinking about there is unmet need in the CML? So around 40% of the patient, they need to change the therapy at some point by 5 years. And only 60% they achieve MR4.5. And why this is important? Because I think TFR is a reality now, and we should discuss this with the patient. And only 50% who have sustained MR4 by 10 years. And approximately 50% with those patients in TFR, they will resume therapy. And don't ignore the vascular events with the TKI. I think it is significant factor. So here came the asciminib. So we have like 2 studies for asciminib. We have ASSEMBLE, approving asciminib as third line, and we have asked for first, where they compare for the naive CML patient, either they take asciminib or comparing with the other TKI. And the primary endpoint was MMR4 at week 48, and the secondary point was major molecular response at week 96. So this is the result. So when you compare asciminib with all TKI, clearly it seems asciminib is the winner, and there is significant MR4 and MR4.5 when you compare with all TKI. But if you go to the second diagram, when you compare with to the third one, when you compare with the second generation, yes, there is difference, but not that much. The clear difference is when you compare with the imatinib. Asciminib, it seems like how I understand the result. So I have now a drug that can give me the result as second generation TKI with the less side effect or toxicity. Here the toxicity, you can see that when you look to the grade 3 or above is less in asciminib. When you look to the discontinuation rate, significantly much less with the asciminib. Regarding cardiac toxicity, is not zero in asciminib. So there is around like 2% chance to have cardiac toxicity when you compare with 2.9 in the second generation. However, imatinib, zero cardiac toxicity. So a clear safe drug. Do we have evidence for using asciminib as second line? Yes, we have just only a real world data. Is an observational cohort study. They have around 500 patients divided to asciminib and second gen and other TKI. Most of the TKI was dasatinib, luratinib, and bozatinib. And they look to the side effect and the safety, and also they look the time to the BCR-ABL to be less than 0.1, which is the MR3, or BCR-ABL less than 0.01, which is the MR4. So here the result, you can see the discontinuation rate with asciminib is around 4.6 versus 10% in the other arm. Regarding progression to aplastic or acceleration phase is almost zero with asciminib. Here the median time to the MR3 and MR4 is around 30 months, the time to the MR3 versus 39 in the other TKI. And regarding the MR4, 59 versus 72 months. And they conclude that asciminib is a good is higher rate of major molecular response as second line with less toxicity. So this is the NCCN guideline. So if you have a patient low risk, then you decide to use a TKI, you can see imatinib still there, and this is category 1. Second generation is a category 1 as well as the asciminib. So now you have 6 or 5 or you have a TKI, one asciminib. So how I should choose for the patient? What factor that's going to help me? So it is a big argument when you sit with the CML expert. So you need to have these data. You have to evaluate the disease, the face of the disease, the prognostic score of the disease, even the transcript type, which is, I think, most of the center they don't have. And what about the type of the TKI, the offside effect, and the strength and the mode of use? Like with the nulatinib, you have to fast for 6 hours. Also the patient profile, age, comorbidity, lifestyle, the expectation, and your goal. What is your goal? Is your goal just to prevent transformation to a plastic face with good quality of life, or you are looking for a TFR? Also the drug availability and the resources you have. And just to remind you here, the CML patient, when you come to you, they already Google it, the CML. Is a blood cancer. When they read it's blood cancer, it's scary. They came most of the time panic. So you have those patients who come to you like well-educated, questioning you. And I think this is the patient that you can looking for the best goal of therapy for him, because you are confident that he will realize the side effect, he will follow with you. And you have that patient in denial phase. He come to you, he just came because of the family, and you try to explain everything. You meet him first and second, and he's still in the denial. And you have those patients in between. He's compliant, but he's not asking a lot. He may be not noticing the side effect. So this is the journey of the TFR. So TFR is a reality in the standard practice. So for example, if you have a CML, like 100%, they will start a TKI. And then when you meet the criteria of the TFR, which is you need a TKI therapy for more than 3 years if you are using second generation, or 4 to 5 years if you are using the first generation. You have to know the BCR-ABL transcript. You need the patient to be in a deep molecular response for at least 2 years. And you have to make sure that he's able to follow with you monthly. And so if you meet the criteria, only 50% you will attempt in them. And who will have successful TFR is around 25%. This is the criteria of this continuation. I just brought this slide to show you the amount of the restriction, the amount of the side effect that when you want to use the drug, you have to consider it. For example, those with the arterial events, nulatinib, bunatinib, it seems is not a good option. Severe hypertension, asciminib and bunatinib is known to cause hypertension. Those with the pulmonary hypertension, you have to avoid dasatinib, for example. And those with the pleural effusion, dasatinib, nulatinib, also known to cause and so. So what about looking for that tyrosine kinase domain mutation? Do we need to look for that at the diagnosis? According to the European guideline, no, it's not recommended either for chronic phase or even de novo blast phase. But those who's in treatment and we start to notice resistance, yes, is recommended. These mutation will not happen unless the patient is already in TKI. This is the incidence of the mutation, and the commonest one is the 315. This is just show you that if we have this data before, then you can't choose between these targeted therapy based on the mutation you have. Some of the mutation, they are resistant. So this is a good paper by Tim, and he looked to the probability of EMR or molecular response failure defined by more than 10% BCR-ABL at 3 months. And is dependent on the intensity of the kinase. So you can see the imatinib, the percentage of fail is around 34%. This is for the all CML patient, compared with the 6 with bunatinib or 9 with the nulatinib. Based on the SOCR score, you can see those high risk is almost 60% if you use imatinib. To have a BCR-ABL more than 10% at 6 months, at 3 months, sorry. So you have to discuss with your patient. You have to decide about the goal, and you discuss with the patient. Am I just avoiding transformation and looking for the good quality of life and avoiding drug toxicity? I'm looking just for long-term control, or I'm looking for a TFR. So this table, I'm just trying to use like 3 factors, which is what is the priority for TFR, the risk score, and the comorbidity, which is mainly the cardiac toxicity. This table was made during a meeting with the CML expert from Europe and also from the Saudi Arabia. And we can just take an example, those with low priority for TFR, you have very elderly patient, frail, and he has cardiac toxicity, but the score was low. So we know those with the low score, they have a good response for imatinib. So here, imatinib came as first choice. Second, asciminib, and then dasatinib. So as we know, dasatinib doesn't have significant cardiac toxicity. When you look, if it is high score or high prognostic score, then you have to think about asciminib. Yes, there is kind of cardiac toxicity, but is much less than the second generation. And if you have high priority for TFR, then even if the score was low and the cardiac toxicity is high, you need to think about asciminib. It seems there is no role for imatinib in such group of patient. Where asciminib monotherapy may not be the best choice is mainly for the very elderly, frail with the cardiac, with significant cardiac toxicity or comorbidity. Patient with a 6L1, and this is happening in around 7% of the CML. And it seems patient with a 6L, if you use asciminib, they will have more mutation of the ABL. And also the rare patient with a BCR ABL transcript, which does not include ABL exon 2 or 13.3 or 14.3, which is only just one person from the CML. Usually we don't have these data when you start to treat the patient. Just two slides, one about the conception and the fertility. So TKI therapy in general appear to affect some male hormone, at least temporary, but does not appear to have a significant effect on the male fertility. Miscarriage, fetal abnormality is very rare in the female partner of a male patient with CML. TKI therapy during pregnancy has been associated with both higher rate of miscarriage, fetal abnormality, a prolonged washout period usually need if the patient they planning if a female patient planning to get pregnant, and any CML patient in general recommendation, you have trying to convince your patient to not to get pregnant until you get her in TFR if this is your goal. If that's not possible, at least for the first 2 years, to be in a good response. Regarding using interferon regarding using the, how we approach for those who's already got pregnant while on TKI. So usually you have to stop if the patient in TKI should be stopped immediately, the TKI. Usually you monitor them trying to be monthly. You have to involve your colleague from the obstetrician and the gynecology to monitoring the patient. And what option we have? We have alpha interferon. It's safe during the pregnancy. As we know, this is the initial drug used for the treatment of the CML. And you can use this temporary, trying to stabilize what you did already achieve with the TKI. At least the first trimester. So after trimester, if you're noticing the BCR-ABL is getting increased, then you can consider a TKI. What is the safest TKI? Nulatinib. It seems less chance to cross placenta. However, from the practice, we have a lot of patients who's got pregnant while she's imatinib, and they seem doing fine. So in summary, there is no single TKI is the best frontline choice for all CML patients. Imatinib, nulatinib, dasatinib, bozatinib, asciminib, all best choice in individual cases, is case by case. Current approved doses for second generation TKI may be higher than optimal for many patients. And I think good to have more new drug like asciminib, because clearly there is still unmet need for the CML patient, especially those younger in younger age. I think on time. This is the last slide, just to show you the CML. This is the CML in the early phase of diagnosis, and see the late chronic. Usually you have more evolution, more mutation, or even driver mutation. And thank you.
Thank you. Thank you, Dr. Ayer. As usual, You know, you are talking about the CML, which is a fascinating topic in hematology. So the common questions and in what we face in the practice, young female who is coming with CML and she is willing to get married. So what is your first
And
choice?
she's what?
She is willing to get married.
Yeah.
So what is your first TKI? Where you place a Semenib in this regard?
So I have a scenario, just I'm going to mention the 39 years old female who came to me, newly diagnosed. She was panic and she was in a great stress at that time. She's not yet married. Then we start her on imatinib at that time. And just only 4 months, she back to my clinic and she gonna get married after a month. So she got a good news and bad news in just around 5 months. And then her sister came to me and mentioned clearly she's 39 and she's gonna get married and she's thinking about to get pregnant. I talked to her about the risk. I talked to her about the standard of care, which is she needs to be in contraceptive method for at least 2 years. We are trying to do our best. Like if she agreed for this plan, she will not get married for the 2 months. I will be more aggressive for this patient. I will never consider imatinib because I need a rapid molecular response. So I will go with the second generation. Given she's young, so probably she will tolerate the toxicity. So initially she agreed for this plan. We started in the dasatinib. And then just after 6 months, she got pregnant. And her BCR-ABL is less than 10, is less than 1, I believe, but still is not an MR4. And she went to our colleague in the gynecology, and they told her clearly there is high risk for transformation. And just I want to remind you that the first slide I presented, which is the phases of the CML. So, I mean, we diagnose them incidentally. So if there is no treatment, they have up to 6 years before progressive acceleration case. Why I'm mentioning that, you have to understand the patient, what she wants, and because some patient, just for simple MBN, they get divorced because they start in hydroxyurea and they end up with, when they read about it, the chemotherapy, and she just, because of the toxicity, she get divorced. So yes, we are trying to follow the science, but we apply the patient on the science rather than apply the science on the patient. So anyway, she got pregnant. I stopped after 6 months, I stopped the dasatinib. I start interferon. We're lucky that we have the biggest at that time. And I maintain the BCR. It keep increasing, just reach around 5. Then I get her back strongly in the dasatinib. So to summary, think about stronger second generation or asciminib to achieve a rapid major molecular response in such patient.
So just small question about the elderly. Are you going to follow the milestones, MMR, or just you will be liberal with the patient? Like if the molecular response less than 10, it will be okay for you?
Yeah, I mean, we have those patients, all of us, we have those patients with less than 10, but because they are elderly, frail, and you're looking here, your target here is avoiding transformation to the aplastic or acceleration. And I think we can achieve that with the less toxic drug. I wouldn't like pushing hardly to get them to the MR4 or MR4.5.
Okay. I think with that, thank you, Dr. Ail. So we'll move to
So we move to our next talk, and this talk is going to be presented again by Dr. Badr Al-Ahmari, and he's going to talk about AML, focus on menin inhibitors.
All right, Assalamu alaikum, good afternoon again. All right, thank you for the organizer to invite me to present this talk that has been assigned to me. So it's good to talk for the first time about AML without mentioning 7+3 and FLAG-IDA and others. So we're going to talk about only targeted therapy here, and with the focus on menin inhibitor. So as we know that acute myeloid leukemia is one of the first cancer ever get sequenced and it is very heterogeneous with complex molecular background with acute myeloid leukemia. Common mutations are FLT3, NPM1 considered to be one of the most common mutations with acute myeloid leukemia, but it's associated with other multiple structural cytogenetic abnormality and molecular aberration. We depend on the molecular data. We use them for classification of acute myeloid leukemia, and also we use them for risk stratification. So we risk stratify patients with acute myeloid leukemia based on their molecular data to favor or intermediate and adverse. ELN 22 risk stratification based solely for those who received intensive therapy, but also even for those who received less intense therapy, we still can classify those patients and their molecular profiling using a handful of molecular gene mutation to classify those patients. But the most important thing is, can we do this even not only for classification, risk stratification, but also as a targeted therapy and kind of precision medicine? And that's what we're going to talk about it today. So we'll focus on NPM1 mutated AML and also KMT2 rearranged AML, where this kind of leukemia that can be targeted by the use of menin inhibitor. So NPM1 is, again, within the NPM1 leukemia, it's very heterogeneous leukemia itself. So we can have different outcome for patients with NPM1 mutation. It's highly associated with the co-mutation. The most common co-mutated genes with NPM1 is FLT3, ITD, followed by TNMT3A, TIT2, and IDH1 and 2. And different other mutation, but those are the most common associated co-mutation. So what's the difference there? Because we can still have different outcome depending on the co-mutation. We know that NPM1 without FLT3 consider favorable risk regardless of the other genes, but also if there is NPM1 and FLT3 ITD, it's considered to be intermediate risk according to the ELN criteria. However, this has been challenged based on the recent data from the Harmony. Harmony study or Harmony registry is a big registry based on in Europe, which constitutes at least 6,000 of AML patients. So they extracted only patients with NPM1 mutation, around 1,000 patients, and they look into their different outcome based on the co-mutational status, and they were able to generate a new risk stratification based on very few number of co-mutations, and you can classify patient within the NPM1 mutated patient into intermediate, favorable, intermediate, and adverse. For example, patient with triple mutation, which is NPM1, FLT3 ITD, and DNMT3A, consider an adverse risk disease, and transplantation in the fairest remission, probably it's justified in this scenario. So, although NPM1 looks favorable, however, for relapse refractory, there is a different story. Patient with NPM1 mutated, once they get relapsed, there are no difference between their outcome of NPM1 mutated patient versus non-NPM1 mutated patient or wild type NPM1. So, indicating really an unmet need for relapse refractory NPM1 mutated patient. This is a nice data illustrated from MD Anderson. What about KMT2? KMT2 rearrangement, we can see it in different kind of leukemia. We see it in AML, ALL, mixed phenotype, but with a different percentage. For example, infantile ALL, up to 80% they are KMT2 rearranged and associated with better outcome compared to what we see with other kind of leukemia. Adult ALL, around 5 to 15% of cases. In acute myeloid leukemia, around 6% of cases, especially the de novo. But we see KMT2 rearrangement in patients with secondary or therapy-related AML up to 10%. We know that this is associated with topoisomerase 2 inhibitor, and we can see this after like 1 to 2 years post topoisomerase 2 inhibitor chemotherapy exposure. There are more than different partner, translocation partner we can see with the KMT2 rearrangement. The most common one is MLLT3, which is at chromosome 9, and this is the most common than the one that we see. It is associated classically or traditionally known to be associated with probably a little bit better outcome than other partner. The most common partner with ALL is different, which is the one in chromosome 6. Again, data from the Harmony registry, the European-based registry, they extracted patients with KMT2. They found that it is only 3 to 6% of all AML cases in Europe. They are actually KMT2 rearranged. And then they try to extract their data and analyze them. And what they found that the most common co-mutation is actually NRAS and KRAS mutation. These are the most common co-mutated, and also followed by FLT3 TKD. And within even the KMT2 itself, the co-mutation also play a major role. If there is TP53 or NRAS mutation, this was actually associated with worse outcome in combination with KMT2. And you can see here that KMT2 rearrangement associated with poor outcome, even from the upfront, with the use of upfront setting. And you can see, specifically for this data, there was, which is something new, there was no actually difference between 9/11 translocation versus others. In acute lymphoblastic leukemia, KMT2 also associated with poor outcome with increased risk of relapse. However, there was recent data from MD Anderson's showing that incorporation of immunotherapy with the upfront treatment, including blinatumomab and the inotuzumab, was associated with improvement outcome and obliterate the adverse risk of KMT2 in upfront setting. All right, so how we can target KMT2 rearranged and NPM1 mutated AML? The target will be menin. So in normal cellular components, the KMT2 is actually work as an epigenetic regulator that binds to the chromatin to regulate box gene, but to be able to bind, it needs menin to help the KMT2 to bind into the chromatin and regulate box gene. Box gene and other set of genes actually responsible about maintenance of normal hematopoiesis. So what happened with the KMT2 rearrangement, that the KMT2 rearranged molecule which binds with the menin, it actually upregulates box gene and lead to uncontrolled dysregulated hematopoiesis and differentiation arrest, and that's what happened. For the NPM1, it can interact with the normal KMT2 and menin complex and make it behave like if it's KMT2 rearranged, again upregulate the box gene and other set of gene and lead to dysregulated hematopoiesis. So whenever you introduce a menin inhibitor to control the menin itself and remove menin from the equation, there will be no interaction between either the normal KMT2 in case of NPM1 mutated or the KMT2 rearranged with the box gene. So you will restore the normal hematopoiesis and stop the differentiation arrest. So far, up to date, there are 2 menin inhibitors that are US FDA approved. We have revumenib, approved in 2024, initially for any KMT2 rearranged leukemia in general, including pediatric population, and subsequently it was approved for NPM1 positive acute myeloid leukemia. Ziftomenib is another agent that is approved only for relapse refractory NPM1 mutated acute myeloid leukemia as a monotherapy. So we have 2 agents. So what are the data that led to the approval? Starting by Augment trial that tested ALL and AML patient, KMT2 rearranged and NPM1 rearranged, but I will try to separate them for you. So initially, the KMT2 rearranged acute leukemia. This is a phase 1 and then phase 2 study using revumenib as a single agent, population median age 34, primary refractory 24, and AML was 80% of cases. Very few cases of ALL, only 12% of cases they are ALL. Again, most common translocation 9/11, RAS mutation is the most common associated gene, but most importantly that around half of patients, they have at least 3 and more line of therapy, and half of patients at least, they have prior allogenic stem cell transplant, and 70% of patients, they are actually exposed already to venetoclax, so they are refractory to venetoclax, indicating a heavily pretreated population. This has resulted in overall response rate of 63%, CR plus CRH around 22% for this heavily pretreated population of KMT2 rearranged leukemia. And we'll talk about median duration of CR/CRH was actually 6.4 months. And there was some MRD negativity. Around 70% of patients, they achieve MRD negativity. Looking into the median duration of response, as I mentioned, 6.4 months, and median overall survival, 8 months. Not a great numbers, but for some like KMT2 rearranged leukemia with heavily pretreated population, indicating that there are some signal there that this is a treatment that can work for this heavily pretreated population. For NPM1 mutation, extracted data from Augment 101 study, the efficacy population was 64 patients enrolled into this efficacy. They analyzed in this efficacy population with an overall response rate of 47% and CR/CRH around 23.4%. Within this population, around 70% of patients, they have prior transplant, 1/3 of patients, they have 3 or more lines of therapy, and 70% they are venetoclax exposed population, and IDH1 and IDH2 population were within this set of patients. FLT3 ITD or around 1/3 of patients. And speaking about response were equal. However, patients with IDH1 and IDH2, they show the better responders. In terms of safety for this, for revumenib, less than 5% of treated patients lead to treatment discontinuation. So this is really significant, indicating that the treatment is not really toxic as we see with different agents in leukemia setting. Around 20% of patients, they have more than grade 3 or more QT prolongation. So this is something we need to be aware of. Differentiation syndrome can happen. Grade 3 and more, 13% is a significant percentage, indicating someone who already have symptoms requiring oxygen and need discontinuation and intervention at this stage. Febrile neutropenia, 13%, compared with, for example, with venetoclax, much favorable. Duration of response was 4.7 months, the median duration of response, EFS 3 months, and overall survival was median was 4 months. What about ziftomenib? Ziftomenib, again, tested for NPM1 and KMT2 relapse refractory as a monotherapy. And you can see the initial data showing that ziftomenib might not be as good as what we see with revumenib. And you can see the gray bars. These are the KMT2. So it didn't really work well with KMT2 rearranged leukemia. So it's primarily approved for NPM1 mutated acute myeloid leukemia. This is the data from phase 1, phase 2 study, the COMET 001. Enrolled 92 patients, median age 69. Around half of patients, they are FLT3 ITD population. 24% of patients, they have previous transplant, and 60% they are exposed to venetoclax previously. 1/3 of patients, they have at least 3 and more lines of therapy. Again, a pretty heavily treated population. In terms of adverse effects, as we saw with the revumenib, there are risk of QT prolongation, probably to the lesser degree when compared with revumenib, but differentiation syndrome is still there. Febrile neutropenia at around 26%. Cytopenia is there, but not really significant as what we see with other agents. Can we advance the slide? Okay, that's fine. Okay. So looking into responses, the CR rate was 14%, and CR/CRH was 22%. And the median time to first response was 2.8 months, 60% MRD negativity. And if you look to the duration of response, the median duration of response was 4.6 months, a little bit equivalent to the revumenib, and median overall survival was 6.6 months. All right, so now we'll move quickly to the menin inhibitor in combination with other agent. We have a combination of revumenib with the AZA venetoclax in newly diagnosed newly diagnosed NPM1 positive and KMT2 rearranged AML. And this is the schema that they use, which is the standard AZA-ven plus revumenib. And you can see the responses here. The overall response rate or composite CR is around 81%, which is a little bit higher than what we see with the standard AZA venetoclax alone. And responses were seen across different patient population. And you can see even the responses are a little bit higher and better quality of responses we see with the KMT2 rearrange rather than NPM1 mutated AML. So indicating that the combination might be, will be a future for KMT2 rearranged and NPM1 mutated patient. Median overall survival was 18 months for KMT2 rearranged leukemia in newly diagnosed and 15 months in NPM1 mutated patient. Another study that was presented during the last ASH, which is the SAFE trial. This is a triplet combination using only oral medication. So oral revumenib, oral decitabine, and oral venetoclax. So this is an oral triplet combination in newly diagnosed AML with KMT2 rearranged and NPM1 mutation. Very few number of patients, only 14 patients NPM1 positive and 7 of KMT2 rearranged. Very, very small number of patients, but there was a good signal here including high overall response rate of 86% and high CR rate of 76%. Again, this is only a combination of oral regimen with a median, with the overall survival at, median was not reached, but overall survival at 12 months was 57%. I think this is my last slide, the menin inhibitor data that was presented during the previous EHA and previous ASH. Here are some updates. For example, for ziftomenib, combination with AZA venetoclax was tested in the relapse refractory and also in the newly diagnosed NPM1 AML. Again, you can see that there is a high overall response rate, 89%, and high CR rate of 76%. Bleximenib was also presented in a Camelot trial in relapse refractory setting. The overall response rate is also still equivalent, 47%, but the CR rate is somehow better than revumenib and ziftomenib as a single agent, as a monotherapy. In a combination, we can also see a newly diagnosed NPM1, a very high overall response rate at 93%. But also in the relapse refractory, we can see a 91% overall response rate in relapse refractory setting with the use of this combination. Also, it was combined with the 7+3 enzomenib as well as the latest one was presented at the ASH 2025, showing a relapse refractory an overall response rate of 73% as a monotherapy, which is compared favorable to the previous two agent, with a CR rate of 40%. So key points, so at present we have two menin inhibitor approved by US FDA, ziftomenib and revumenib, and revumenib approved for KMT2 rearranged and NPM1 mutated patients. Ziftomenib is only approved for NPM1 mutated patients. Monotherapy demonstrates some favorable responses, but they are not really durable. I think the combination strategy is going to be the key over the next few years. What's the best way to combine them with other agents, whether the use of AZA venetoclax or more recently the oral decitabine with the venetoclax that was approved recently for acute myeloid leukemia. And with that, I conclude and happy to take any question. Thank you for your attention.
Thank you, Dr. Badr, for this a nice review of menin inhibitors and AML. Now, these data are very much expected, the usual like we have experience with FLT3 inhibitors. So the targeted agents, they have activity against, the relapsed refractory or even newly diagnosed patients, but that is, limited activity, and the duration of responses are usually not long-lasting. So combination therapy obviously is very much, the promising. One question, which is usually the next step in these patients, is: are you aware of any studies using these agents as a maintenance post-transplant? So patients who had NPN1 mutation and they relapsed and had a transplant, or KMT2A inhibitors as a mutation and they had a transplant. Are there any studies of menin inhibitors as a maintenance?
I'm not aware about specifically for maintenance, but they do allow patients who go into transplant to continue the use of revumenib. But I'm not aware about specific study for maintenance.
I think that will be interesting to see, in future, because theoretically that will help these patients, and they may reduce the relapses post-transplant, but we have to see the trial data. So we have time, maybe, just for one last question.
Dr. Badr, thank you for your elegant lecture. My question about MBM1 doesn't seem all the patients the same. What is your experience with MBM1 mutation patient? How they respond?
Yeah, I agree with you. I mean, as I mentioned, that MPM1 is within itself is a heterogeneous disease. You can see different outcome with the MPM1 mutated patient. What we know of is the associated FLT3 associated with less outcome compared with wild type FLT3. But again, the Harmony data clearly showed that the co-mutation is a big deal here, and I think it produced different outcome with the MPM1. So we have to be careful when to decide about transplant for MPM1 mutated patient. I'm not sure about the next ELN update. Are they going to really rely heavily on the data from the Harmony study or not? But to be honest, we've known this since a long time. Even the paper in the New England Journal of Medicine 2016 of Papa Emmanuel showing clearly that MPM1 influenced heavily by the co-mutation status.
The other questions about the field moving now from conventional chemotherapy to targeted therapy such as menin inhibitors. So what about the MRD in this regard? They are using we are just focusing on morphology. So what about the mutation itself by MRD, NGS, and PCR?
Yeah, as I mentioned, there was high MRD negativity associated, and this was one of the things that they were following, like using the KMT2 fusion protein as an MRD, and also the NPM1, the mutant allele as an MRD. And there were higher MRD negativity, 60-70% of patients. In the combination therapy, up to 80% MRD negativity. So I think this will play a role in the future to determine what will be the next step, whether to go for transplant or not. As we already know with the intensive care therapy.
Thank you very much.
Thank you.
We will move to the next speakers. Dr. Rawan Al-Muhammadi. She is a consultant at the Division of Acute Hematology Stem Cell Transplant in King Abdulaziz Medical City, Riyadh. She is going to tell us about the MBN overview. Dr. Rawan, the floor is yours.
Okay, assalamu alaikum everyone, and thank you Dr. Ahmed for the introduction, and thank you organizers for the invitation. Today I'll talk about management in myelofibrosis in general with some updates. So as we all know, myelofibrosis is one of the chronic clonal stem cell disorders that is characterized by atypical megakaryocytic proliferation with overproduction of cytokines with resultant fibrosis and probable transformation to acute myeloid leukemia. It can present as a primary phenomena, and it can happen as a result of or post other MPNs such as polycythemia vera and essential thrombocythemia. There are a spectrum of There are a spectrum of manifestations in myelofibrosis. So as we can see here, we have patients who are early in their disease and basically they have no symptoms. And these represent almost a third of patients in myelofibrosis. And as disease progresses, we start to deal with constitutional symptoms like night sweats, weight loss, and fever. We deal with hypercatabolic symptoms such as bone pain and fatigability. Some symptoms related to organomegaly, specifically hepatosplenomegaly, which is a result of extramedullary hematopoiesis, and cytopenias, which can be a big challenge to deal with. And the clinical phenotypes of myelofibrosis can be variant, but we can distinguish two major subtypes. So we have the myeloproliferative myelofibrosis, which essentially presents with leukocytosis, sometimes thrombocytosis, and with or without mild anemia. And then we have the cytopenic myelofibrosis, in which patients do have cytopenia in one or more cell line. They tend to be or tend to have higher risk disease with more blasts and more fibrosis. And interestingly, they do have a low allele burden of the driver mutation. Those patients do have other high-risk mutations usually, and overall they have a bad overall survival and a higher risk to transform to acute leukemia. We have three driver mutations in myelofibrosis. We have JAK2, which is present in 60% of patients. We have the CALR mutation, which can occur in 30% of patients, and the MPL, which can occur in 5 to 10% of patients. In the presence of these mutations, there will be an activation of the JAK-STAT pathway with resultant overproduction of cytokines and the biology of myelofibrosis, which is proliferation and eventually fibrosis. We have a very special entity in which we don't find any of the three driver mutations. Those are the triple negative myelofibrosis patients. We have to identify those patients because they tend to have very bad overall survival. And in case we didn't find any driver mutation, we usually look for other clonal markers. So we search for other high-risk mutations such as ASXL, IDH2, and etc. This is just to show you that the driver mutations are not only diagnostic, but they can be prognostic. From here, we can see that the overall survival of a myelofibrosis patient is different. So the best survival is seen in CALR mutated patients with almost 18 years of overall survival. And the worst is the triple negative myelofibrosis patients. And in more details, the CALR mutations do not act the same. So the type 1 CALR mutated patients do have a better overall survival in comparison to type 2 mutated patients. And when we want to prognosticate the myelofibrosis patients, we do have multiple scoring systems. So we did have initially the IPSS, which was developed back in 2009. It contained 5 clinical parameters, and we usually use it at the time of diagnosis. Then the dynamic IPSS was developed, and we can use it, of course, at any time of disease course. And with better understanding of molecular biology, we integrated the molecular information into the scoring system. So we have the MIPS and MIPS 70+. And it's important to mention that these scoring systems, the purpose of developing these scoring systems was mainly to determine the overall survival. This is the first thing. The second thing is to know when to refer a patient for transplant. And we should not use those scoring systems to guide treatment specifically with JAK inhibitors. So after diagnosing a patient, how do we treat? The first question or the first thing we should decide is or position is transplant. So when do we refer a patient for transplant? Generally speaking, if a patient lies in the higher risk group, we usually refer for transplant. So just going forward to, this is the updated recommendations for the EBMT and ELN. So any patient who, the first recommendation is any patient who has a high risk scoring system and a low or intermediate myelofibrosis transplant scoring system should be evaluated for transplant. And in patients with a lower risk disease, so DIPS intermediate or intermediate 1 in general, who harbor features of high risk disease such as TP53 mutation, are considered for transplant. The third point here is age per se is not a contraindication for transplant. So even in patients who are elderly, if their performance status is generally favorable or good, probably considering transplant is still an option. Can we go back one slide? Can we go back, please? Yes, so after positioning transplant, the question is the patient symptomatic or not? So depending on symptom, we'll start JAK inhibitors. If the patient is asymptomatic, probably observation is the best standard of care. If the patient is symptomatic in terms of like splenomegaly, constitutional symptoms, then transplant, JAK inhibitors are the things to be initiated. So we have 4 approved JAK inhibitors. Ruxolitinib is JAK1/2 inhibitor, and its main side effect is, in addition to hematologic toxicity, is latent infection reactivation. So we have possibility of zoster and TB reactivation. So probably it's wise to vaccinate patients and screen for TB. Fedratinib is a JAK2 inhibitor with FLT3 activity. The FLT3 activity could potentially explain the GI toxicity that happens with fedratinib, and we must not forget the serious side effect, which is Wernicke's encephalopathy. So any patient who will be started on fedratinib should be screened for thiamine deficiency, and we should replete as needed. The third is pacritinib, which is a JAK2 inhibitor. And what's interesting about pacritinib and momelotinib is that they are ACVR1 inhibitors. ACVR1 inhibition does lead to hepcidin suppression, better iron mobilization, and better erythropoiesis. That's why it's helpful in cytopenic myelofibrosis. And with pacritinib, we see some GI toxicity. Momelotinib is known to cause some neuropathy. So starting with ruxolitinib, it was approved based on the COMFORT 1 and 2 trials. So we can see here the results from COMFORT 1, where ruxolitinib was compared to placebo. The endpoint was spleen volume reduction at week 24, and it did have very good responses, with almost 42% of patients achieving the endpoint. COMFORT 2 did compare ruxolitinib to best available therapy, but the SVR was, the endpoint was SVR at week 48, which was achieved in 28 patients. Interestingly, other than spleen volume response, ruxolitinib did prove that it did improve symptoms and quality of life in both studies. And long-term data did show better overall survival with ruxolitinib compared to placebo and best available therapy. So ruxolitinib does show good outcomes, but unfortunately this is not for all patients. That's why models such as response to ruxolitinib at 6 months was created to predict who are the patients who will not do as well with ruxolitinib as others. So the poor parameters included: first, the inability to maintain a good dose of ruxolitinib due to cytopenia. The second is inability to or failure to achieve clinical response in terms of spleen and constitutional symptoms. And the third, which is most important, is the anemia and RBC transfusion. We can see here that the higher risk groups did do bad in terms of overall survival. So why do some patients not respond to ruxolitinib, or they don't do well with ruxolitinib? There are 4 clinical scenarios. So we have a patient who do respond initially to ruxolitinib. They don't respond initially to ruxolitinib, and these are primary resistant patients. We have patients who do respond initially, but then lose the response, and this is what we mainly see in practice. For those 2 patients with ruxolitinib resistance, we suggest that the TKI should be changed. So we can use fedratinib, momelotinib, or pacritinib. Or ideally, if there was an investigational drug to be added, this would be the ideal thing to do. How about in ruxolitinib intolerant patients? So they are usually intolerant because of cytopenia, mainly anemia and thrombocytopenia. If anemia was the main issue, probably starting a non-JAK inhibitor anemia-directed therapy such as erythropoietin, danazol, or even luspatercept, which is currently under trial. Or if there were no improvement in anemia or transfusion requirement, probably momelotinib should be initiated. In cases of severe thrombocytopenia, probably switching to pacritinib is the most reasonable thing to do. And the 4th explanation of ruxolitinib failure is progression to acute leukemia. So moving to pacritinib, it was approved based on the PERSIST 1 and 2 trials. So in the first, here we can see the results or the outcomes of the 2 trials. So in PERSIST 1, they compared pacritinib to best available therapy, and interestingly, they did not exclude patients with anemia and thrombocytopenia. So we can see the result that pacritinib arm did do well in terms of spleen response and symptom response compared to best available therapy. And in PERSIST 2 trial, they did focus more on patients with thrombocytopenia, and they did test multiple doses of pacritinib compared to best available therapy. So we also can see here that pacritinib with the current approved dose, which is 200 milligrams BID, did show better responses in terms of spleen and symptom. How about pacritinib and transfusion independence? So this is a sub-analysis from the PERSIST 2 trial where they looked at transfusion independence in the study population. So using different criteria, which is first Gale criteria and simplify criteria, and without going into details of those criteria, we can see clearly that the pacritinib group here showed in the yellow bar, they did very well, and they pacritinib over showed good responses in terms of transfusion independence. And the third important thing about pacritinib is how will the thrombocytopenic patients do with pacritinib. So this is a pooled analysis from the PERSIST 1 and 2 study, where they looked at patients with severe thrombocytopenia or platelet less than 50, and patients with this severe thrombocytopenia did do well in terms of spleen and symptom response, even with cytopenia. So this study showed that cytopenic myelofibrosis patients do well with pacritinib treatment. So the last thing I would like to cover today is what's beyond JAK inhibitors. So we have multiple targets, multiple therapeutic options are being studied, and most of these options are combination therapies. So we have multiple targets to be tested. So we have the BET2 inhibitors, we have the BCL2 inhibitors, we have the PI3K inhibitor. And what is usually done in clinical trials now is the combination. So they combine a backbone of JAK inhibitor, which is usually ruxolitinib, plus another novel agent. And the aim of these studies is deeper response, probably reducing the molecular burden, and probably improving overall survival. So I know we're having a talk tomorrow on the novel agents in myelofibrosis, but I'll quickly mention a few examples. The first is the MANIFEST-2 study, where they tested the BET inhibitor, pelabresib, with ruxolitinib. So one arm received pelabresib and ruxolitinib, and the other arm received ruxolitinib plus placebo. And the primary endpoints were spleen volume reduction and symptom improvement. So I didn't include the graphs here, but it did show durable, this is the most important, durable improvement in spleen response and anemia. And what's interesting is that with the combination, there were fewer deaths and fewer progression to acute leukemia. The second interesting study is the Transform-1 study, where they combined navitoclax to a BCL2 inhibitor with ruxolitinib. So again, the other arm was ruxolitinib plus placebo, and again, it did show good outcomes, promising outcomes. And the last thing I want to talk about is, and probably the most interesting thing, is a new novel agent, which is a monoclonal antibody targeting the CALR-mutated myelofibrosis patients. So this is a very early phase study, but there are promising results. So it targets the mutated stem cells, and it does improve like overall, spleen size, symptoms, and outcome in general in those patients. So probably this is the where we're heading in terms of myelofibrosis treatment. And with this, I end, and thank you very much.
Thank you, Dr. Rawan, for your comprehensive presentation. Any question for Dr. Rawan? Yes.
Is there any role for corticosteroids in patients with cytopenic myelofibrosis or cytokinemic myelofibrosis, or those with these symptoms with myelofibrosis, not just hypersplenism or splenomegaly?
Yeah, steroids is one of the best available therapies that were included in some studies. So it did show some benefits. So probably giving a trial of steroids for patients with symptoms is reasonable, and we can give it a try.
So thank you, Dr. Rawan. The question in my mind is, you know, myelofibrosis, we are just treating symptoms. So any emerging medication that's alter the nature of disease status?
So the novel agents that I just quickly went through are promising, and the initial endpoint of those studies was like spleen volume reduction and symptom improvement, but I think longer-term follow-ups can be helpful in deciding if we can reach a cure in myelofibrosis or not. But until now, nothing is approved, and nothing is approved for cure of myelofibrosis.
So thank you, Dr. Rawan.
So it is my pleasure to introduce our next speaker, Dr. Ayman Al-Muzaini, who is a stem cell transplant and cellular therapy consultant at the National Guard Hospital in Riyadh, with advanced fellowship training in leukemia and bone marrow transplantation from the University of British Columbia. Dr. Ayman is a board-certified adult hematologist with experience in allogeneic and autologous hematopoietic stem cell transplantation, hemoglobinopathies, CAR T-cell therapy, gene therapy, and transplant-related complications. Dr. Ayman is going to talk about from evidence to action, real-world management of myelofibrosis patients. And this is a GSK-sponsored talk.
Thank you so much for letting me having this great opportunity. I know we are at the end of the day. Hopefully you'll not get sleep during my presentation. So I'll try to be more focused and to the point. My talk is a consolidation to my colleague, Dr. Rawan, who greatly spoke about myelofibrosis. In my talk, I'll be focusing more about the subcategory of patients who are having anemia with myelofibrosis. So disclosure, this is my disclosure sponsored by GSK. JAK inhibitor treatment in myelofibrosis have seen great improvement and development during the last 1 or 2 decades. And we can see in the last 6 years, we have multiple JAK1/2 inhibitors approved, including fedratinib, pacritinib, momelotinib. The Jakavi already covered by Dr. Awan. These are the multiple phase 3 trials that were conducted on ruxolitinib in terms of Comfort 1, 2, and the JUMP trial, and multiple real-world analyses which showed great improvement in response in SVR 35 and total symptomatic score. And delving into more those subset of patients and changes in hemoglobin levels over time in patients in both trials in Comfort 1 and 2, we can see with the initiation of Jakavi, usually patients reach a nadir of hemoglobin drop of during the treatment from week 8 to 12, and some smooth borderline recovery of the hemoglobin into new steady state by week 24. This is usually attributed to reduction in the spleen volume and improvement in hematopoiesis. And the fedratinib data here was conducted in multiple phase 3 trials. Jakarta is a phase 3 trial of fedratinib versus placebo. They have included patients who are JAK inhibitor naive, intermediate to or high risk primary myelofibrosis or secondary myelofibrosis with palpable splenomegaly, absolute neutrophil count more than 1, and platelet more than 50. And their randomization was double-blind into 3 different cohorts. Fedratinib cohort were 2 cohorts, 400 milligram and 500 milligram group, and then the placebo was the 3rd group. And they've been following patients from day 1 until the primary endpoint of week 24 with primary endpoint SVR 35. And then afterwards, patients were allowed to have extension arm of open label to be crossed over to fedratinib 400 or 500 milligram dosage. And the approved dose of fedratinib was 400 milligram. And the secondary endpoints were total symptom score, overall survival, and PFS. And we can see here from the characteristics baseline of patients, the 2 cohort or the 3 cohorts were mainly actually similar in terms of age, gender, and risk stratification and hemoglobin levels. And as you can see in the Jakarta trial, the rate of primary endpoint SVR 35 was significantly higher in the fedratinib group compared to the placebo. Also, the secondary endpoints of TSS 50 for fedratinib were higher compared to the placebo. It did really reduce the splenomegaly and burden of symptoms compared to the placebo group. And then when we look further into the hemoglobin levels over treatment period, those who started the treatment of 400 milligram, we can see a drop reaching a nadir in between week 8 to 16 and hemoglobin level, then recovering with recovering to a new baseline around week 24 for patients on fedratinib. However, those on the dosage of 500 milligram, they did not have nice recovery in the hemoglobin level, and that's why this led to the approval of the dosage of fedratinib of 400 milligram for myelofibrosis patients. And the safety profile for this JAK inhibitor was mainly the main side effects profile of GI toxicity and anemia of grade 3 or more events were more than or equal to 3 events were 30%, and those are the main side effects for the medications. However, a group of patients, after examining the trial, they have developed, around 8 patients developed vernix encephalopathy, and this led to termination of the trial of Jakarta 2, which led to FDA box warning for encephalopathy in patients with getting treatment fedratinib, and recommendation to have baseline thiamine level measurement before initiation of the treatment and frequent monitoring of the level. However, if patients who are in a facility where thiamine cannot be measured, a supplementation is always recommended for such patients. The Jakarta 2 is a single-arm phase 2 trial of patients who are previously treated with ruxolitinib, intermediate to or higher risk primary myelofibrosis or secondary myelofibrosis were included with ruxolitinib resistant or intolerant with palpable splenomegaly, and the primary endpoint was SVR 35 at week 24. So it was open label, and patients were followed until week 24 where the primary endpoint of SVR 35. And the secondary endpoints were total symptom score and the change from baseline spleen volume at week 12 to 24, plasma concentration of the drug, and the JAK2 allelic burden. So this trial, as I said before, was terminated after the FDA placed a clinical hold on fedratinib due to reports of suspected Wernicke encephalopathy. However, at the time of data cutoff, the results were actually great for the primary endpoint. We can see 30% or 31% of SVR 35, and in the intention to treat population. And the secondary endpoints was also achieved in 27% of patients. Again, the main side effects were GI-related toxicity and anemia and thrombocytopenia. So fedratinib is an oral JAK2 FLT3 inhibitor indicated for the treatment of adult patients with primary or secondary myelofibrosis. There's the FREEDOM trial incorporating thiamine monitoring and GI adverse event mitigation strategy leading to a lower rate of GI adverse events than in the Jakarta 2 trial. So pacritinib already talked about in the previous presentation. It's just quick mentioning that it's FDA approved in the United States for patients with platelets less than 50% of myelofibrosis of 200 milligram BID dosage. And now going to the momelotinib clinical data, there are three main clinical trials for the momelotinib. So the mechanism of action of momelotinib, it holds a unique mechanism of action. There's a combination that inhibits JAK1, 2, and activin A receptor type 1. So we know in the JAK inhibition is extremely important in the myelofibrosis pathobiology. JAK in myelofibrosis or myeloproliferative neoplasm in general, it's well known that there is a constitutive activation and dysregulated JAK signaling, and due to this, this activates the STAT proteins which control gene transcription, impacting inflammation, hematopoiesis, immune regulation, and a gush of cytokines and chemokines, leading to massive splenomegaly and toxic cytokines to the stem cells and erythroid growth and stages of growth of erythroid precursors and other hematopoietic precursors. The other part is that the beauty of momelotinib as well, the ACVR1 inhibitor, we know it inhibits this ACVR signaling pathway, which suppresses the hepcidin, and hence hepcidin, if it's high, it usually reduces the iron trafficking, and if it's low, this results in restoration of hematopoiesis and better trafficking of iron, and hence increasing the hemoglobin level in such conditions. So this is the phase 3 trial, prospective trial, multicenter SIMPLIFY-1, going into a subgroup analysis of such patients with a hemoglobin of less than 10. So the design is usually, those patients were included, the number of subjects 432. They were JAK inhibitor naive patients, platelets more than 50, and the scale of severity of prognostication of those patients, intermediate 1, 2, and high-risk patients. And the primary endpoint was the SVR 35 response rate at week 24. So they were followed in randomization fashion from day 1 to week 24, and after that, an open label extension of momelotinib was allowed for long-term follow-up. And in the characteristics of those patients, we can see actually they're quite homogeneous between the two groups of patients who are getting momelotinib and ruxolitinib. And the transfusion independence rate at week 24 and hemoglobin levels and platelet counts over time, we can see here the transfusion independent rate between the two cohorts, that momelotinib has higher transfusion independent rate compared to the ruxolitinib part or cohort. And the maintenance of that transfusion independence and level stabilization of level of hemoglobin are actually maintained during the trial from this initiation of momelotinib until the primary endpoint cutoff. Also, we can see improvement in the hemoglobin levels of patients who are crossed over from ruxolitinib to the momelotinib part. Here also we can see down in the mean platelet counts. As we can see, the platelet counts in the momelotinib group patients were actually stabilized, and then the crossover from ruxolitinib to momelotinib kind of reached a stagnant flow of both platelets and the hemoglobin. The sub-analysis in patients with hemoglobin 10 in the Simplify 1 group trial, we can see here again the week 24 efficacy endpoints, including rates of SVR35, total symptom score, and transfusion independence in patients with hemoglobin less than 10. The SVR was quite similar in the total symptomatic score, though numerically higher in the ruxolitinib group, but not statistically significant. However, when you have a peak into the transfusion independence, those patients on momelotinib have higher transfusion independence compared to the ruxolitinib group. And the safety profile for the momelotinib control, the momelotinib patients, common non-hematological treatment related adverse events were more of diarrhea, nausea, dizziness, and fatigue, which were mostly grade 1 or 2. Anemia was experienced in 12% of patients, and thrombocytopenia, which were mostly grade 3 or 4 hematological toxicity. The momentum this is another phase 3 trial, and the design was conducted for momelotinib, and the eligibility criteria was JAK inhibitor exposed, hemoglobin less than 10 and platelet more than 25, and the patients were randomized between momelotinib and danazol, 2-to-1 ratio, and after week 24, patients were allowed to switch as open label phase extension into momelotinib. And the primary endpoint was total symptom score 50 response rate at week 24, seeing superiority, and transfusion independence at week 24, non-inferiority. And here, the baseline characteristics between the two groups, which are quite similar and homogeneous, and we can see the efficacy in the and the transfusion independence in the momelotinib and danazol group. We can see the total symptom score on the left side is in the total symptom score in the momelotinib group is getting like 25% compared to the 9% danazol, and in the transfusion independence 30 compared to 20, and the SVR 35, 22% higher compared to 3% in the danazol cohort. So the transfusion independence rates at week 24 levels were in the secondary endpoint, as a secondary endpoint, were non-inferior in the momelotinib group compared to the danazol. We can see here the hemoglobin and platelet levels count over time over the trial. Steady state of both the hemoglobin and platelets were achieved throughout the duration of follow-up of patients until even the open label period extension period. So analysis of momelotinib patients with thrombocytopenia and anemia comparable or better efficacy was observed in patients with baseline thrombocytopenia and anemia when compared with the overall populations of each study, and the treatment effect of momelotinib versus ruxolitinib on response rates were numerically comparable or better in thrombocytopenic patients when compared with the overall JAK naive populations. This is very, very quick summary of the two studies. Here we can see in the patients in the Simplify 1 JAK inhibitor naive patients, the SVR was comparable, total symptom score, though numerically higher for ruxolitinib, but not statistically significant, with good improvement. But however, transfusion independence was in favor of the momelotinib. And in the momentum data, we can see the symptom score is better for the momelotinib as well as the SVR35, and the transfusion independence was not inferior to the counterpart of danazol. So pooled safety profile from all the trials, Simplify 1, Simplify 2, Momentum, of patients treated with momelotinib 200 milligram daily in the randomized treatment period. Mainly the main side effects were, the most common side effects were infections, and then followed by other like cytopenia, thrombocytopenia, GI toxicity, which were all managed with either dose reduction or toxicity mitigation strategies. So this is a real-world data from the Spanish experience. We have two real-world data, German and Spanish experience. The objective were to offer valuable real-world evidence regarding the efficacy and safety of momelotinib. It was multi-center retrospective analysis across 74 centers in Spain, using strict 2024 IWG criteria for anemia response, and the follow-up period was 5 months. And the treatment starting dose of momelotinib 200 milligram daily, and population were mainly elderly, median 73, however ranging from 42 to 87, JAK naive or JAK exposed, primary or secondary myelofibrosis. So we see heterogeneity in the population here. And we can see here the efficacy outcomes in terms of transfusion independence. About 45.7% of transfusion-dependent patients achieved transfusion independence in this data. And spleen response, 62% of patients showed spleen volume reduction, which met 24% of met the strict IWG criteria. So the adverse events were mainly thrombocytopenia was the most common hematological adverse event, and 17% of the population in the data required dosage reduction. So these two real-world data of the MOM-GIMFIN Spain and in the German group showed great transfusion independence in this patient, transfusion dependent anemia in 21% in the German group and 45% in the Spanish cohort. So quickly discussing key management or key criteria in those patients, discussing key considerations in the management of myelofibrosis. We know from large data, more than 1,100 patients with primary myelofibrosis from Mayo Clinic, institutional-based databases, that patients with anemia and thrombocytopenia, the severe the anemia, the more severe the thrombocytopenia, they have worse overall survival compared to the age-adjusted cohort of patients with myelofibrosis. And the more transfusion-dependent patients, they have higher risk of disease progression and decreased overall survival compared to their counterparts of transfusion-independent patients. I will conclude my presentation with a case that I have been seeing in the clinic. So I got a 82-year-old gentleman presented to the ER around April 2025 with fatigue, angina, weight loss, and pallor, and requiring blood transfusions. It was a complex case of hematologic malignancy and significant cardiac history. So the cardiac history for this patient, he had coronary artery disease, underwent stent twice. In 2015, he's on heart failure medications. He had subdural hematoma, 2023, for which he underwent evacuation surgically. And then he presented to me with those symptoms, and examination was unremarkable for hepatosplenomegaly, lymphadenopathy, or lumps and bumps. Initial blood counts were as follows: hemoglobin was 8, the white blood cells were 34,000, mainly of neutrophils. Basophils were a little bit elevated, 2.6, eosinophils 0.8, lymphocytes 3.4. Blasts were not increased, actually they were not detected. The neutrophil were 23,000 and platelets 1,400. His creatinine and LFTs were unremarkable. So the peripheral smear showed leukoerythroblastic picture, suggestive bone marrow filtration or fibrosis. There were many ovalocytes, elliptocytes, teardrop cells, polychromatic cells, and few nucleated RBC, red blood cells. Lift shift in granulocytes and basophilia, and thrombocytosis was confirmed. And the bone marrow biopsy was dry aspirate. It was dry tap. The cellularity was 90%, which is very high for his age. He's 83 or 84. And the pathological findings were no increased bone marrow blasts by morphology and immunohistochemistry. However, the fibrosis grade was 2, and this was going with myelofibrosis. And molecular genetics, he was JAK2 positive, SRSF2 positive, and was negative for MPL, CALR, and BCR ABL. The spleen was normal in size, and though with the disease burden, it was like he had no splenomegaly. So by MIPSS score, he was high risk. ECOG was 2. He was transplant ineligible because of his age, comorbidities. So what to do in this stage? The treatment for him was kind of difficult. I started him. This is, as you can see here, the white blood. This is the hemoglobin levels from the time of diagnosis throughout the journey of his treatment. So when I faced him in the clinic, I started him on erythropoietin in hope to increase his hemoglobin, and with a temptation to do Jakavi. Over almost a month, there was no great response. He was requiring blood transfusion almost every week. And then when I started ruxolitinib, his blood transfusion requirements even increased. I could not really give him the proper dose. So I even decreased to 5 milligram Jakavi, and he still was requiring blood transfusions almost 1 or 2 times per week. His life quality was impaired. His heart failure medication, he was coming every time to the emergency department with decompensated heart failure because of severe anemia. So I tended to stop the Jakavi and requested momelotinib at that time. It was part of the compassionate use program. So until the arrival of the medication, I looked into possible alternatives and started lenalidomide, dexamethasone. And with the initiation of, it was started around September, until almost mid-November, lenalidomide with steroids. It did really decrease the burden of blood transfusions from like 1-2 times per week into 2 times per month. However, patient was still symptomatic. And then around December last year, momelotinib was started, and he only required 2 blood transfusions at the first 3 weeks. Afterwards, actually his hemoglobin had been stabilized, and he was back to his hometown, coming less frequently to the clinic, with the hemoglobin levels completely normalizing over time until the last encounter with the patients at mid of April this year. So we are talking about level from almost 6 grams per deciliter to 12.5 gram of hemoglobin. White blood cells as well, they were 35,000. They decreased to a normal level around the course of treatment. And platelet counts, he was having thrombocytosis, also improved with the treatment. So novel agents in myelofibrosis, we are in the era of multiple options and shifting gears in treatment of myelofibrosis, multiple attempts to revolutionize the therapy of myelofibrosis, and clinical trials are undergoing. We can see multiple targets here are exploited: selinexor, telomerase inhibitors like amitelostat, MDM2 inhibitors to restore the TP53 activity, driving the apoptosis of myelofibrosis. The medication is called navtemadlin. Epigenetic modulators like pelabresib, BCL2, BCLXL inhibitors, navitoclax, and luspatercept, all are great options, will be part of the treatment, ancillary and armamentarium for myelofibrosis in the near future. Here I conclude and thank you.
Thank you very much for this excellent presentation. Now, when you have a chronic disease like myelofibrosis, which is hardly curable, and you have multiple lines of therapy available, one of the most important questions is how to sequence those therapies. So some of these JAK inhibitors, we know that when to use them, like when the platelets are low or when the patients are really dependent on transfusion. So regarding fedratinib, I want to ask you, in which patient you will consider fedratinib, and at what stage, at what the line of therapy?
So patients, or I would still use fedratinib, though it the trials were terminated because of possibility of vernix encephalopathy. When they've looked into those patients, almost 9 or 10 patients who developed vernix encephalopathy, they were having baseline malnourishment and severe GI toxicity, and their baseline thiamine level was actually on the lower side. And with GI toxicity mitigation strategies and thiamine supplementation, actually there were no further cases of vernix encephalopathy. I would still use fedratinib in patients with intermediate to and high risk patients, usually who are not really responding to Jakavi. It really has great SVR35 response, also great total symptom score response in those patients. So it's still on the table. It depends on the patient preferences and the previous history of the lines of therapy for those patients.
Thank you. So we have time. Are there any questions from the audience?
Dr. Ayman, last case, what you mentioned, thank you first for your elegant presentation. You said you stopped ruxolitinib and then you shift to momelotinib. So any role for tapering down ruxolitinib and shifting at the same time, giving 2 combination therapy?
Yeah. So we know holding ruxolitinib abruptly could cause cytokine release syndrome or cytokine storm-like features, and you have to cover those patients with steroids sometimes in order to decrease the kind of rebound cytokine gush inhibited by the Jakavi. I did not really shift the patient immediately from ruxolitinib to momelotinib. I did some steroids with lenalidomide as a bridging, then I shifted the patient to momelotinib at that time. So the stop of ruxolitinib was from 5 milligram BID to 5 milligram once daily, and then stopped that and started the steroids immediately.
I think this is really a concern regarding cytokine syndrome if you stop the ruxolitinib abruptly. But do you really need to taper the ruxolitinib if you're starting another JAK inhibitor? Because I don't know, we don't have much experience in the new JAK inhibitors, but they probably also they cover the same area. So it's probably less likely that they will have a some similar kind of the cytokine syndrome if you're starting a new JAK inhibitor, although mechanism is different for different JAK inhibitors. So what do you think?
I mean, if you, I haven't had any patient who actually developed such thing. It has been mentioned in the literature, though very scanty data on such phenomena. But if I have the luxury to taper the medication, I would do it rather than stopping that abruptly and subjecting the patient for possible dreadful side effects, especially elderly patient with multiple cardiac comorbidities. Their ability to tolerate such phenomena may be less compared to the younger patient population. In terms of taper, I would definitely, for those who are higher dose, prolonged treatment, I would just taper and allow washout period before starting the next therapy.
I think it is definitely, one has to be cautious, but I think the actual incidence is quite low. When we have patients from time to time who are on ruxolitinib and it was stopped abruptly for some reason, patient stopped them themselves, or for some other reason, some other physician stopped it, and alhamdulillah, we never got any
Nothing
problem.
happens,
Yeah.
yes,
But definitely one has to be careful. Do we have any question from the audience?
Yes, Dr. Ayr.
Just a comment regarding switching between the JAK inhibitor. So ruxolitinib is a JAK1 and JAK2 inhibitors, and it is strong JAK1 inhibitors. When you compare, for example, with bicatinib is sparing JAK1. And significant withdrawal symptom, usually we're noticing in the clinic if you just withdraw or stop the ruxolitinib, when you switch from ROX to the other JAK. But if you do the opposite, for example, from bicatinib to ruxolitinib, these symptoms much less because we are sparing the JAK1. So strongly we recommend overlapping. So it's depending on the dose. For those in high dose, definitely you need to taper over weeks. This is one of the options. And when you reach to the 5 milligram ruxolitinib, either to corticosteroid and stop it and then go to the other JAK, or just start the 2 JAK. Because what's happening, if you just stop it and you start the other JAK, the patient will have a bad experience of the new drug. And he believes this because of the new drug. The new drug, it needs time to work. And he says, no, I didn't want the new drugs. I want to back to the 5 milligram. It was doing great with me. So definitely this withdrawal symptom, we see it in the clinic. We were just trying to withdraw the ROX. Momelotinib is a JAK2 mainly, but also have a JAK1 effect. Fedratinib, by the way, I think it is more as a JAK2. So any JAK2 inhibitor, it seems less withdrawal symptom, rather when you compare with the strong JAK1 inhibitors.
I think there are no more questions, so we conclude this session. Thank you very much for your presence for this late. Sorry, is it a question or something?
Okay, so I think the closing remark with Dr. Okay, yeah, please.
Thank you. Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Dr. Ammar Sghair. It gives us the SSBMT a great pleasure to thank all the audience and all the speakers and all the moderators for the successful first day of our 15th SSBMT annual meeting. And I'd like to thank everybody in the supporting group also. And remind you tomorrow, inshallah, we'll have another day 2. We will have the first 2 sessions will be the general hematology meeting, and the afternoon will be the nursing day. Kindly, the starting time tomorrow will be at 8:30. We encourage everybody to attend early on time and to utilize the time for discussion, and it will be another successful day tomorrow. And with that, I would like to close and thank everybody again. Thank you very much.